इसको हमारा है कहीं साइड में रखते हैं ये भी उनको फैसिलिटेट करना वी टू फाइंड द साड़ी हियर यस माय गॉड अब कल मैंने ऑर्डर किया था तो उसे वो करना तो चाहिए आपके बच्चे ने सिस्टर नहीं तकलीफ में होती जाना है हां होती जा रही है तो फायदा नहीं करो तो आगे नहीं पड़ते ना
रिकॉर्डिंग भेजनी
ठीक है चेंज मतलब है ये डालूं कैसे जो ऊपर से आगे हाँ डालो ये थोड़ा बहुत स्लो में होते हैं ना
चलेगी
कुछ चाहिए तो कोई नाइफ टाइप की कोई चीज होगी यहाँ पे क्या एक बॉल करते एक बॉल करेंगे ज्यादा नहीं डाला ये तो पकने लगता है बाकी ये भी थोड़ा थोड़ा भी ग्राइंड होता है हाँ वो साइड में रखें ये कितना है अब ना ये नहीं करूँगी हाँ स्लीवलेस है हमको मेरे सारे ब्लाउज स्लीवलेस होते हैं अच्छा आप आती है ना क्या ये तो टेंशन लेते हैं बोलिए क्या हाँ मैंने बता दिया मैंने बता दिया क्या नहीं अपने पढ़ने में अपने आप हो जाएगा बट अब अपने करते हैं बाद में करेंगे फिर अपना अपने आप को कर लेते हैं कुछ तो दिखा के करेगा हाँ आप और करते हैं ना क्या मैं आपको थोड़ा हो गया मुझे जो सिखा देना ठीक है चलिए आ रही है ये सारे सारे पूरी अजीब सी नहीं लग रही ये ऐसी लग
गुड मॉर्निंग। सुनो, किसके पास पीपीटी है? जो जो बेसिस का वैसे नहीं पीपीटी नहीं चाहिए मुझे। कौन प्रोजेक्ट करेगा? हम माइकल यानी की सीवी देंगे। ओके, बिकॉज ये कॉन्फ्रेंस वाले लोग हैं वो तो कुछ भी अब दिखा नहीं रहे ना, बिकॉज लेक्चर्स का लाइव आएगा तो उनको देख के कंफ्यूजन करने से फायदा नहीं है। तुम अपनी पीपीटी में जोड़ लो, एंड में आपको लेक्चर जब मैं इंट्रोड्यूस करूंगी यहाँ पे जो भी जिसके पास ये फोन में डाल रहे हैं, यानी बिलीव कस्टमर्स की पीपीटी बना रहे थे। मैंने सोचा ही नहीं पहले। हमारे काम भी ऐसे होते हैं, कहीं कहीं से ढूंढ ढूंढ के पीपीटी बनाई गई है। कहाँ है आप किसी के पास शीशा है? कहाँ है? अच्छा इधर शीशा नहीं दिख रहा। मैं वही रास्ते में कर रही थी, वो ठीक से नहीं दिखता। तो वॉशरूम में है तो मैं हमेशा रखूं करती थी शीशा, लेकिन अब तो ना पर्स
अरे वो थोड़ा भी तेज हो गया थोड़ा करके ऊपर से
इसके पास नहीं है क्या? कौन पीपीटी में दिखाएगा?
अरे मुझे लगा तुम्हारा साइज के हिसाब से नहीं तो ये तो छोटी हो जाएगी।
ये वाली ठीक है ना? ठीक
आपको देखो
नहीं एग्जाम में नहीं गाड़ी में बैठ के उसकी पीपीटी उसकी सीडी बनाएगा माइकल यानी।
अच्छा
वो तो बंदा इतना महान है, वो तो उसमें तो 4 महीने की थी, मैं कंसल्टेंट थी। मतलब
हाँ वो लोग ये ऐसे बस सीधा सा
ठीक है है भी नहीं इस तरह का ना, थोड़ा सा बंदा भी बड़ा होता है। मैं वहाँ बीच में थी ना, तो बहुत ही है बड़ा ही मजेदार। तो ये सुना मैंने भेजा के लिए हॉस्पिटल में हम फोन करते थे ना, तो वो जैसे उठाएगा ना वो ज्ञान नहीं करता मैंने भेजा।
अच्छा
बहुत ही मजेदार होता है। आधे घंटे में करना भी मैं शीशे में शक्ल देखने गई हूँ। शीशा रखने की आदत ही छोड़ के रास्ते में ले चली गाड़ी फोन में लगा फोन में नहीं दिखता
मैंने ये वाला
तो लेकिन उसमें क्लैरिटी नहीं आती, अच्छी नहीं है। मैं रास्ते में पता है यानी की सीढ़ी बना ली क्यों किसी की बात बनी उसमें तो कुछ भी नहीं है, खाली लिखा कंसल्टेंट ऑफ अच्छा वहाँ पे आपको नहीं बना मैं किसी को उसमें कर दूँगी नहीं मैंने यही मैं चलो सब मेल नहीं करेंगे मेल करेंगे मैंने गाड़ी बना के मेल करते हैं तो चलिए मैंने अभी यहाँ पर है मेरी इसमें जो एक्सपर्ट नॉलेज नहीं और बाकी सब तो ये सजाने के लिए ये उनको देने हैं यहाँ पर आपको ये दोनों उनको देने मैम उसको और
हाँ समझे मैं जूम कर लेंगे कोई भी कर सकता है मैं तब तक अपने वाले पे कॉन्फ्रेंस हॉल में डाउनलोड कर रही हूँ उसने ग्रुप पे डाला है ना रेजिडेंस वाला ग्रुप पे ना ये आ जाएगी मैं कॉन्फ्रेंस हॉल में तो कॉन्फ्रेंस हॉल में जाकर कनेक्ट किया आपने ना पंकज ये हाँ मैं पीपीटी ये रहा पीपीटी वो ग्रुप पे है हाँ ग्रुप से पीपीटी निकालना है और उसमें निकाल लिया वो है ठीक है
पहले मुझे अपने को व्हाट्सएप गुड मॉर्निंग ये क्या हमारा इनॉग्रेशन जो है 15 मिनट का है वैसे तो क्या ये जूम पे जा सकता है तो कर दो प्लीज हम वहां से तो बस कर दो क्योंकि नहीं तो जो लोग ऑनलाइन जुड़ेंगे उनको तो ब्लैंक सही रहेगा ना सब कुछ तो हम ठीक 9 बजे हम शुरू करेंगे और फिर ओटी का ट्रांसमिशन आप ऐसे 8:15 और 9:30 से स्टार्ट कर सकते हैं चलो भाई that's important ऐसे ऊपर का सुनो मैं यहाँ पर लोग ना 18-20 तो बैठे ना तो यहाँ पे मैं किसको ऑर्डिनेशन दे सकता हूँ किसी ऐसा लेवल को या इसको जो ये जना स्केल का सब ऊपर से रिजन है जस्ट टू बोल ले ये ऐसा कोई नहीं अच्छा मेरा आपकी बात है ये जस्ट ऐसे तो ये हो सकता है जब ऊपर है तो नीचे कोई कोऑर्डिनेट करती है और जस्ट नो लाइव भी है नहीं नीचे पता क्या होता है कि कोई कुछ पूछ रहा है कर रहा है तो हां ये चाहिए सीनियर और जो थोड़ा सा संभाल भी पाए चाहे वो 15 ही लोग हो लेकिन ज्यादा से ज्यादा डिस्टेंस है चलो कुछ पूछते हैं तो डायरेक्ट पूछ नहीं सकते चलो नहीं हो गई है आप हां चलो ये कोई आवाज समझी को मॉडरेटर काम डालते हैं किसी को आवाज से अगर मैं कोई तो लेगा तो बता लेते हैं हम ये बनाया है कि इसके नाम ही 2 घंटे बुला रहे थे तो उसका नाम थोड़ा सा वो ऑडियंस से वो करना है इसको हां ठीक है जो भी है तो कोई किसी का सवाल हो तो ये ट्रांसलेट ऐसे बताओ क्या वो यहाँ पर जब दिल्ली वर्चुअल का वर्कशॉप में देखा था प्राइवेट में because the Zoom link is set up, you will get questions on the chat straight there only. Which we can also see. यहाँ पे एक बार चेक कर देते हो हाँ एक जगह तुम जब जाओ तो किसी को रिप्लेस करना एक जो बंदा हमेशा होना चाहिए और एनीथिंग एट ऑल चाय के पास से निकल और क्वेश्चन आप ठीक है अच्छा किसको व्हाट्सएप करो मेरा पूछने तो मैं He has got the link. I was also with my dear Kashana. सबको लिंक मैंने जाके भेजा है ना इसलिए everybody is working. So this thing is somewhere here.
इसी को लिख गए थे।
हम उसका रीजन है आपको मालूम है आपकी लिस्ट है तो कल गुजरात तो आप भेज
नहीं बिल्कुल भी नहीं। आज देखो ना लिस्ट तो मेरी जो लिस्ट है नहीं हमारी ड्रेस भी ना अभी टाइम नहीं है
जो मैंने रात को चला गई
मेरे गॉड मैंने सीसी करवाया है जो मेरी सीसी आया वो मैंने सब जाके भिजवाए हैं। मैंने 6 लोग को कॉल किया 6 में से 5 लोग को मेल दी थी तो मैंने सुमित को कॉल किया सबको लिंक दोबारा भिजवाए गैलन को तो गया ही नहीं थी कोई लिंक कोई गैलन को कॉल नहीं किया। He said I was nothing new then I called to I said this is really not done। एक फैकल्टी है इंटरनेशनल स्कूल दिल्ली किया फिर उसको मैंने पूछा आई विल शुड चेक आउट जिससे मुझे आपको अभी तुम्हारी बात हो गई इससे हमेशा से नहीं अब सब देर रात को बहुत बार इससे कोई बात नहीं है
हां बिकॉज़ ही वाज गेटिंग अ कॉल सर प्लीज आंसर मच कॉल
हां वो सबको लिंक रात में किया गैलन वाला आई बट
अंजलि डबरा तो मेरे समझ आ रहा
अंजलि डबरा को मुझे पता है कि 6 लोगों को कॉल किया एक जने को लिंक मिला था वो भी टूटा सबको दोबारा किया सारी लिस्ट
चलो दैट्स सॉर्टेड आउट
तो मैं रास्ते में कॉल कर रही थी लोगों को लिंक मिला नहीं और वो विकास उसको मैंने पूछा सबसे पहले मेरी टीम ने भेज दिया होगा तो बहुत पहले का नाम से क्या किसी मैं क्रॉस चेक कर रही हूं तुम्हें क्रॉस चेक करना है तो ये उसको सर तुम्हें क्या मैं ट्रस्ट नहीं वर्क में जो बोला आई डिड नॉट ट्रस्ट यू बट वो तो मेरे को मेल नहीं है मुझे तो पता है नहीं बट जो लिस्ट 3 दिन पहले जा रही थी वो भी उनको भी गई ना बार वालों को तो छोड़ ही दो बार वाली आपकी टीम को कुछ बार नहीं चला हां वो इसमें वो भी चले वो मेरे लिए मैंने कहा मैं सोऊंगी नहीं जब तक मुझे देख नहीं जाएगी ये बात से शुरू वाली बात मेरे साथ आई नो मेरा तो सुनना आई थिंक मैं को वाला वाला है जैसे तुम्हें तो हो जाएगा कि मतलब ये बात उसका रिश्ता ना पड़ा वो वाला कि मैं जाके ठीक है वो उनके पास अब बस इसी का है माइक का अंदर बदलना तो गैलरी में चलेगी वो सब क्या क्या बोला अच्छा That's my speculation.
That's not really because they were performance in professional coach. They were I think mesmerized. They were like for 50 years like not easy. But बाकी लोग हैं हमारे वालों तो मैं receive from but they had really I mean and the meeting was in charge oh I mean they charged among the speakers last year was the body to that इस तरह की चीजों के लिए पर महेश बहुत बारी करते थे जो आईसीसी आ रहे हैं ना वो लोग भेज देते हैं प्रोफेशनल ब्यूटीफुल डांस करने वाले
ये हमने दूसरा बार खोलने के लिए हमारे ऐसे ज्यादा है ना कब आएंगे लोग नहीं हाँ मैंने कुछ बोला हमेशा इसको रखो वापस इसको बुला लेते हैं आपकी कलर वाली बट वही वो आपने लगा था किसी में नहीं बदलना नहीं बहुत ही खूबसूरत मेल कर दूं क्या अरे मेरे पास नहीं अपने आप मेल कर लूंगी शुरू दे रहा हूँ मुझे करना उसकी साइड बहुत अलग होती है मुझे पता है लेकिन यूजलेस Sorry, इसको ट्रेनर पे अनाउंस करेगा जैसे बीच में थोड़ा गैप्स होते हैं कंसल्टेंट इसे पूछ लेना क्या बोलना है ये यूज करने के लिए और जो भी बीच में गैप्स लगे ना जब देखता कि कंफ्यूजन ना आए तो उसे बीच में परिवार क्या मिले उस पे उसको ट्रेनर के देना आप एक्चुअली क्लैशिंग विद यूजर that's it but उनकी मेन बात है हमारा वर्कशॉप I get it आप लोग को मॉर्निंग 9 to 12 बजे लगा बाहर एक नेशनल के साथ कर रहे हैं इंटरनेशनल है हमसे सिडनी टू वानकूवर हमसे ज्यादा कोई नहीं कर सकता मैंने अपना टाइम जोन देखी है तो मैं तो बहुत क्रेजी है तो रात में सुबह वालों को रात हम भी तो रात वालों को 9 तक ले जा रहे हैं और आपको मालूम है लिंडा विलिस was so enthusiastic so California she was at 6 a.m. from California she was in like 6 because of the घंटा clock is clock is it's 1 here तभी तो पहले 7:30 no but when I said another 9 o'clock जब उसने बोला तो उसने like 8 बजे पर वो बोलने के लिए वो बेचारी लॉगिन कुछ 6 बजे साढ़े 7 के बाद 7:30 से 6 बजे टाइम देगा लगता है उसका टाइम हो स्नैप हो गया तो देन वी हैव टू डिस्कस यार ये बस बात होगी है so the police told me नहीं it's not fair बेचारा है 6 बजे से बैठी है चेक अप में नहीं और द डायरेक्ट she is from 6 o'clock I also had to record that was nice उसका बल्कि शॉर्ट एंड क्रिस्प था हेलो professional plan ठीक है नहीं मेरा है आपके पास तो बस मेरा बड़ा है बड़ा प्रोफेशनल काम बड़ा करना है ऊपर लेके भी चला जाता है कुछ प्रॉब्लम और सुन ले इसकी बात करना है सुन ले अपना कैमरा मैन लिया जा देखिए दूसरे ये करेंगे चला गया पासवर्ड है 08117 अजय तो ऐसे ही है 8 दिसंबर तो उसने छोड़ा क्या उसको तो मेरे को लगता गाड़ी में आती है पहुंचा नहीं आज
मैम सुधा मैम इज सेइंग समथिंग आवाज
डॉक्टर सुधा सुन
रविंद्र जी
तू आ जा अब बेटा नाम का ले
मैम यहाँ पे देख सकते हैं
रिकॉर्डेड मैसेज है अच्छा रिकॉर्डेड मैसेज हां और क्या ठीक है मुझे लगा
अच्छा रिकॉर्डेड है आवाज नहीं आ रहा आवाज नहीं बंद किया आवाज बोलना क्या
Extremely privileged and honored to welcome you all to this academic session of 17th Annual Conference of Indian Fertility Society. Before we get started, I would like to express my sincere appreciation to all of you who generously helped us make this event to become a success. Your passion and ideas have helped us to achieve our goal. Today I can see that the prestigious Indian Fertility Society has accomplished a recognizable position among fertility societies.
माइक्रोफोन बोलेगा बेटा है ना बोलने के लिए कौन बोल रहा है जूही को बोल रहा है ठीक है हाय
It will be easier, no?
तो अपना अच्छा वाला कैमरा से पिक्चर दे
Monday is not there.
Hi, good morning. ये छोटी-छोटी चीजें होती है ना करने ऑनलाइन का बड़ा फायदा है
First, huh? और ये मैथ भी है
चलो चलो शुरू करो इट्स ऑलरेडी 9
मैथ भी
it's 9 10
9 के है फर्स्ट पेज है
yeah no we're not like this yeah Lavender follow do we start major जो this thing is middle of a session either you do that I can't leave us sharing
सोनिया रविंदर को बोलना ऑडियो ऑन कर देगा
ठीक है ये खाली इसको डाइस पे फोकस करना है और बाकी तो कोई लोग ही नहीं
समझ नहीं आ रहा सर क्या नहीं बिगड़ी कर रही है
यहाँ पर मूवमेंट ऑन हो गया
शुरू करो चलो
So good morning everyone, and I extend a very warm welcome to all the distinguished guests and all the delegates present here and all those who have joined online platform. And so I'm sure all of you are going to enjoy this wonderful workshop on Hysteroscopy In Art, the pre-conference workshop for Fertivision 2021. So it is my esteemed pleasure that here I have with us Professor Rajeshwari Subramaniam. She is professor and head of the Department of Anesthesia and Critical Care Medicine. So, ma'am, I would request Dr. Meena to give introduction to the program.
call madam first and then give her a.
So ma'am, please come into the dais. So I request Ankush to escort ma'am to the dais.
And madam also, Renusha.
Yeah, and I request Dr. Shweta to escort Dr. Renusha, ma'am. Ma'am, the senior consultant. Bachcha. So ma'am is a senior consultant, she's trying to attend Bharati Institute of Research, IVF Center, and I was former additional professor here at AIMS Delhi. And now I request Dr. Ankush to come on ma'am. So ma'am is professor and chief of ART division, All India Institute of Medical Sciences, New Delhi. I request Dr. Ankush to present her floor welcome to present her plant as just to ma'am Dr. Alishwari.
Yes, no, I just love the color.
Also, I request Dr. Shweta to give this floor to ma'am and Felicity. Okay. So I request all our distinguished guests in the panel to come to the lamp icon CMO.
Please, the other man.
I request Dr. Shweta to present the ma'am floor welcome to ma'am Dr. Alishwari.
Yes.
Thank you, Dr. Shweta. Now I request all my distinguished guests to come to the lamp icon ceremony. I request Dr. Nita to please join the before lamp icon ceremony.
Thank you. Just in the back. ठीक है.
A very good morning to all the people present in the hall and all those who have logged in. So just to introduce the workshop, I think this is a hysteroscopy workshop of a live workshop that we're doing. Over the last 2 years, I think, or rather 20 months, we have not had any live workshops. We've always been doing, virtual mode. So we took this endeavor as part of an initiative to kickstart the live activities. Hysteroscopy is a very integral part of infertility and IVF workup. For the uterine pathologies, though they are lesser in number to account for infertility or implantation failures, but needless to say, that is the way to go forward. When you see a lesion on a 3D or a 4D scans, the only way to handle them is on hysteroscopy. And therefore, keeping in mind, we have kept this workshop, which is going to be interactive live of cases which you see day to day in your daily practices. And the whole idea is to bring forward the concept of office hysteroscopies, doing a minimal anesthesia or rather with sedation. I hope all of you will enjoy, and we'll take back good messages, good learning points from this workshop. I would also request Dr. Renu Mishra to please say a few words on hysteroscopic surgery in ERT.
Good morning, everybody. So it's a pleasure to be coming back to AIMS and doing live hysteroscopic surgery workshop with Professor Neena Malhotra, who's here. Hysteroscopy now, I think it's a must for every gynecologist and particularly an infertility specialist, because seeing is believing. We have very good ultrasound imaging now, but still at times you have to look inside the cavity yourself to be confident that this is a patient where the cavity is normal, particularly in ART patients. So I hope that we can bring some interesting take-homes from the workshop for you all. And we would focus on the practical. So we would be showing you the equipment, how to assemble it, and procedures. And I hope you all enjoy. Thank you so much.
Thank you, ma'am. So, my request, Dr. Gayatri to give this story to, so that Dr. Neena and the translation for the story. Thank you. Thank you, ma'am. I request Ma'am Dr. Alishwari to say a few words. Fantastic, actually. Good morning, everyone, and I'm really very privileged to be part of this program, as well as close associate and colleague of the gynae department as such. And all my friends in gynae would know that I'm the one with probably the softest spot for gynae as far as the patients are concerned. And it is very true that in our country there is a really crying need, not only for saving young mothers and being very careful with their management, but also to manage infertility is, I think, very, very important, because in our country there's a big social stigma attached to women who are unable to bear children. And I think no step is too small to begin with such things. And I think the knowledge of what one can do practically to alleviate this problem should be taken down to all levels of gynecologists and obstetricians who are practicing, so that it doesn't look as if it is out of there for you to do anything for this problem. So big things start in small steps, and Neena, as I've seen her grow, and she's so much into this program and this specialty, and I'm also part of it many times, and I really always hope and pray that the woman who's at the receiving end conceives and the goal is met, because I think that is a prayer in everybody's hearts when we start a lady through her cycles of IVF, which is not only time consuming, extremely, it's a high pressure, psychological, socio-economical kind of thing. I think many family members and people outside also look upon that. So I think there's a long way to go. But I think with such a vibrant department as our gynae department, with Neena taking the lead, I think I'm sure you'll go leaps and bounds and will bring this to the hands of every deserving woman. And I think motherhood should be a part of every woman who really wants it. So thank you once again, and I really wish this program all success. And I'm always, as usual, very keen and very willing to do anything that can take this forward. Thank you once again, Neena, and your colleagues. Thank you so much.
I take this opportunity to thank Dr. Rajeshwari, our head of department of anesthesia, for being the chief guest for today's workshop and inaugurating the workshop. I'm sure with their guidance, we will be doing a good job in the OT today. And I also like to thank all the delegates who joined online and offline. And of course, the faculty, gynae department and residents of gynae department AIMS who have been working tirelessly to make this happen. Thank you.
So, thank you, ma'am. And so we'll just have a short tea break, and then without any further delay, we'll just proceed to the live demo of our cases to the different OT, and then we'll have two OTs running simultaneously, and then we'll relay the interesting cases one by one. So maybe we can meet in another 15 minutes after a short tea break. Thank you all. 10 minutes.
आपकी सामने के साथ यहाँ पर मैं अपने पुराने उन्होंने भी आएंगे ना मैंने भाई आधा सारे वाले यार सुनो ना एक तो ना प्लान में सारे एक ही रखवाना है नहीं तो मैं तो ऑफिस में दूंगा आप कभी भी नहीं ऑफिस में नहीं आओ भी आ जाओ अभी सब पुनः आगे ना चलो आप सब अच्छे ना तुम क्यों सुना मिचा चलो क्यों सुना बैठ के ये सुना या देखो मैं मार दे 30 seconds मार आपने हमारे लैपटॉप को
स्लाइड्स ठीक नहीं है किधर रखा है स्लाइड्स में प्रेजेंट करना है ना हाँ देख रहे हो भाई मैं आ रहा हूँ हेलो मास्क उतारना पड़ेगा ये तो नाइट ड्यूटी से ऐसे होती है।
अरे मैं भी तो नाइट ड्यूटी करता रहा हूँ 1 बजे पहुंचा था।
हेलो हाँ हाँ बोलो हाँ आवाज आ रही है
कम आ रही है। स्लाइड किसका है तुम्हारा? अभी ये प्रेजेंट करना है। किसको सुनाएंगे? सुनाएंगे किसको दिखाओगे आप? वो देखो वो सुरेंद्र जी वो बैठे हैं खाली और ये रविंद्र जी बैठे हैं ये देखेंगे सब।
क्या सब लोगों को मिल जाना है।
ये होना 1 से 3 फिजियोलॉजी का। हाँ वैसे चलाओ नहीं डब्बा ये बात तो आएगा डब्बा भाई मेरा लाइफ तो इसको होता है ना वही दे नहीं किया था वही दे नहीं किया वही तो लगा हुआ कोई बात नहीं फिर तो सारा सम्मान है या भी केवल से बदला मिलना है यार कितना आग लगा कितना बड़ी चाहिए यहाँ से आप मुझे बस इतने ही बच्चे चाहिए अरे तो दे रहे हैं एक सी अब यार अभी लूंगा मैं तो अभी वो नहीं हो रहा था क्या बोल रहे हो हाँ 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 और कोई कोई मैं कर रहा हूँ सर मेरे पास हो रहा है मैं केवल डाल दी कोडिंग पे ठीक है कोडिंग मैंने केवल डाल दी है ठीक है और हाँ सुनिए के बाद एक और है कि बस रेज्यूमे कोडिंग यहाँ से वहाँ तक है तो वो लिख लिया तो यहाँ से यहाँ तक हाँ हाँ और उसको डाल दे वहाँ तक पीछे चल वो पे क्या है पीछे कर डाल चल है ना एक छोटी अपने पास में नीचे हो जाए फिर ये होगा मेरा नंबर दूसरा है ठीक है नाम लिखा है और क्या उधर जाएगा ये चलिए इधर डाल देंगे तो क्या सीधा उधर जाएगा एक साइड है अच्छे से और इसमें लिखा हुआ है हां ओहो ये जो ना इन आवाज को बोला है वो खेल रहा है हां हां आप एकदम लेफ्ट में ये सारा कौन बोल रहा है एक इधर बोल रहा था लड़ाई बोल रहा है ऐसे लिखा है ये बहुत है अब कौन सा बात है जरा यहां से बात है और क्या है आज चलो ठीक है रोज कर रहा हूं ठीक है यहाँ कौन दिया यार हेलो यहाँ लगाना पड़ेगा इधर जाओ दीदी दीदी हाँ 20 से जल्दी कमी है हटाओ उठाओ कैसे लगेगा ये डब्बे डब्बे में बड़ा पेट में लगा दो आने चाहिए क्या गरम जगह क्या डब्बे में देखो ये भी कह रहा है तुम बढ़िया चल बहुत आते पहुंच गया या कुछ डिवाइस भी रहेगा आगे तो डिवाइस लगा के पूरा बढ़ा दो लगाओ आप वो लगाना पहले क्या ये रिश्ता करना है ये ऐसा है मैं आखिरी में हो बहुत गया
तो स्लाइड शेयर कर पाऊंगी ना हेलो
ये वाला हमारे यार
स्नैप के लिए आएंगे क्या फोटो के लिए? हम दोनों की इच्छा है चलने का क्या तो मैं भी अपनी बड़ी हाथ में उससे ले लेती हूँ इसके साइड में जब मैं जलामत देखता हूँ मेरे से भी किसने नीचे की तरफ हाँ ठीक है क्या
अभी करेंगे शुरू रविंद्र जी वॉल्यूम
हेलो हेलो छोटी से आ रहा ना कोई लगा दिया ठीक है ठीक है
या से हमारे खाने को अपने आप
तो वहाँ तो अंजुम वगैरह है जबकि पेशेंट्स अंजुम वगैरह सब मैं तो लगा गलत हुआ अब तो देर हो गया था चैट से आई जाई ना उनको अपने नाम से याद हां देखो नहीं चाहती करते पड़ते कैसे से फोन करा जूली उसने तो फाइल सब साथ में
ऊपर नीचे है ना इसमें लिस्ट है सॉरी यहाँ हमारी जाती है
connected. कौन सी यहाँ जाए सही है ना उधर फर्स्ट is Mahekpreet and this side is Aisha. Let's finally get somebody who is first case. This is first on the. Where is Mahek? Mahek है नहीं. Mahekpreet is this one. This one. It's number 199.
हेलो
I think you care about it,
जी हेलो हाँ जी
आप कौन से है
अरे एक मिनट हेलो जॉन अपना ओटी के अंदर आवाज दे रखी है
कौन सी ओटी में दी है? Lishu, Lishu, can you hear me?
Yes, ma'am.
Dr. Lishu?
Yes, ma'am, I can hear you.
Okay, fine. So, how long, so first we are going to start Mahapneet, right?
Yes, ma'am.
Okay, just let me know, then I'll just brief, I'll give a brief introduction about the case, okay?
Okay, I'm just getting in news now, ma'am.
So section irrigation दोनों क्या है इसमें लिखा होगा section irrigation में लिखा okay and इसमें भी लिखा request all the delegates present here in the conference इस पे तो लिखा first का भी लिखा ठीक है लिखा या बाला शुरू करो So I request all the delegates to please come forward in the conference hall. So first we can have the comments and then we can have the instructors. Anjali? क्या बोला है स्टार्ट करूँ तो मैं स्टार्ट कर लूँगी करूँ अच्छा कौन बोल रहे हैं आप थोड़ी बढ़ाओ आ जाओ Anjali and everyone out there please come forward to the conference hall. First we are going to have a demonstration of equipment by Professor Dr. Issue. Hello and welcome everyone. Those who are on the conference hall live and those who are joining online. So we've got two OPs now which we will overlap so that you will see the one OP at a time. I'm going to start in this OP to show you a new scope which is diagnostic as well as operated from car stores. This is actually the inbuilt betoking. So if you see, you don't need to unassemble any part. The top part is the diagnostic part which has a telescope and an irrigation channel. I don't know, can you focus this? Yes ma'am, we can see. You can see? Yes ma'am. So there is an irrigation and this whole assembly at the front end is 2.9. So it is like when you're doing diagnostic, you could just go in with this part only. And if there is something operative, that means if you want to cut a septum or anything, a polyp, then you can actually slide this, you can slide this scope and bring this channel in front to cover the scope and the irrigation channel, so that now you have another channel which is going to take the side instruments. So the instruments usual betoki, we have a scissor. That's a scissor. Can you see it? Can you see it on the screen?
Yes, ma'am, I see.
Hello, somebody respond.
Yes, ma'am. Can you hear me?
कोई बोला भाई?
Yes, ma'am, we can see.
Okay, so this is a scissor and this is a grasper. So nothing new. Same as what goes through the turkey hysteroscope when we use it, normally when using the turkey, we have these in two parts. We have a diagnostic sheet which we slide onto the telescope, we do a diagnostic, and then we have to operate, we have to remove that assembly, put the irrigation sheet and the side channel, and then we have to reintroduce. So the advantage with this is that you don't have to do that in two steps, and you can simply first do a diagnostic, and if there's nothing to be done, then that's it. You only go through 2.9, which is obviously very comfortable even with many parents and postpartum patients. It's a three-scope irrigation channel, and if you need to do anything operative without an energy source, of course, in this case, then you can simply slide and put the grasper, because scissors are very delicate, So, you can put the grasper or scissor or even an electrode through this. Make sure that this is on, because otherwise you can break. These are very delicate instruments. So the port should be on so that there is no movement. And you can then take this grasper out. And it will come in the door when it is gone through. So that's a grasper. So it is just 2-in-1 turkey system, which has been incorporated so that you don't need to remove the diagnostic hysteroscope and then inside the turkey with the scissors. So this is about the scope, which is called character trophy. Yes?
Ma'am, can you just please show once more how do you slide it? I think it's not focused.
Okay. So this is at its zero position. That means when you're going to go in first with a diagnostic, this tip here, this much, it basically consists of the telescope and an irrigation channel. The two here, the scope and the irrigation channel. And the whole assembly here is only 2.9. So you basically go inside, like we do hysteroscopy, standard hysteroscope. You go inside, look inside, and then if you think you need to introduce a grasper or scissor, then there is a little knob here which you press and then slide this to cover the irrigation channel and the telescope. So you've got another shape going in without removing the hysteroscope. That is the advantage. So you slide this in, and now it is ready to take in an instrument. These are usually 5 French.
Yes, ma'am, now it's clear.
And you can introduce this from the side channel. Make sure that this is open and you don't force anything because they are very delicate instruments. And you can come through and operate as you do the standard turkey. So this is it, and I will now demonstrate with Piyush. No, sorry. Who's coming? Tushar. They will help now to demonstrate the hysteromat. You can have a hysteromat which is all in one incorporated. Can you now actually focus on the, and this is a Karl Stone's endomat select, which actually has 2 parts. If you can see, so the top one is the irrigation and the bottom one is suction. They look very alike. So this is irrigation and this is suction. You attach the tubing there and then you set the pressure. You set the irrigation pressure and you set the suction pressure. Irrigation pressure, the range is 100 to 150 millimeters of mercury. So usually we are keeping around 100, maybe sometimes 110, 120. As we know from our basics, that the irrigation pressure should be lower than the mean arterial pressure. So if somebody's blood pressure is 130/80, then ideally it should not be more than 100. Because if it is more than arterial pressure, then you are forcing the fluid into the intravascular system under pressure. And that is why your deficit increases, and that is how you can land up with edema or other complications which can happen with non-ionized solutions like calcium. The bottom one, the suction system has, you can set it from 0.3 to 1 bar, which is the unit of pressure. Usually we keep it at its minimum around 0.3. And sometimes, like once in a while, we need more pressure, transient, we can actually sort of control that from the hysteroscopy. But that's what we set in the suction. So that's the irrigation and suction. And now, other. So here if I show you, this is the tubing which goes for irrigation. It says clearly irrigation FC. And on this side it says it can be used for surgery, neuro, biologic, GI. So it is, the endomet can be used for irrigation in any of these surgeries. It is not unique to biology. And similarly, this one says, if you can see on the screen, it says suction. And again, it says your bowel and neuro. So we are going to basically because we are done intraluteral or intracerebral procedures, we know the constant suction. Where in laparoscopy, you know that we put a different kind of suction where the suction pressures are higher. So this is meant for gyno and for like what we do the hysteroscopic surgery and like urologist to bladder biopsy or anything that we go into the bladder. So, Mr. Prashad will show you how it is attached. Let's attach the irrigation first. So on this screen you can select whether you want to go in for gyno, nephro.
Basically, we'll have to.
आपके पास माइक है कैसे बनोगे फ्री माइक है एक बड़ा माइक फ्री माइक Are you ready that side? Are you ready to start surgery? So in the meantime, I can show you the whole system that we made for hysteroscopy. So standard, that's the monitor. Monitor, ready? Okay. Camera. And then of course all these gadgets we do not need for hysteroscopy because we don't need an insufflator. Okay, so this is the light source. This is a recorder. This is IDA recorder for documentation. And what is that? Multi-switch.
Multi-switch from this is for routing and signal switch.
Okay, so that's so okay. So this is the oscillator which is used with the Bugatti shaver, and that's the cautery machine at the bottom, and this is the irrigation section. So we don't have this oscillator in this trolley. So this entire trolley actually is for use for hysteroscopy equipment. मलिक आप यही ले लो यही ले लो
Otherwise, okay. I will just keep speaking. Yeah, you can do it. So he is now going to put the So what he's saying, because he doesn't have a mic, he's saying that the tubings are different when you're doing laparoscopy or hysteroscopy. The basic connector is the same, but the tubings are different. अब इसको लगा ही दीजिए because next case में हम शुरू करेंगे, तो इनको focus करें. So when you lock it, the lever has to be pulled down so that it is fixed. Yeah, now it is closed position. Now it gives you the option saying irrigation pressure and you can set it. So if you can see the screen of the irrigation, you can, like I said, from 100 to 150, and the flow rate you can set from 200 to 600 ml per minute. Okay, the suction attach करिए उसको. हाँ, okay. Just started. So उनके पास चला गया क्या? हाँ, बस just 1 minute. So the surgery is going to start in the other OT. So the same way it is attached here in the suction, the connector is the same. You lock it, and then you set it how much pressure you want. Like I said, okay. Okay, so 200 on the screen is 0.2 bars,
And now let's move to the other OT where Dr. Neena Malhotra has already started the case, or she's just going to start, maybe waiting for us. So over to you, Neena. Juhi?
Yes, ma'am.
Okay, see, so good morning, everybody. Juhi, by the time we are going in, you can show the PPT there, or maybe one at a time. Fine. So this is a 24-year-old young lady who came with primary infertility, and everything was normal, regular cycle, semen analysis normal. Baseline scan, when we did, we found that she had on 3D imaging, 4D imaging, she had a septum. So we did not see a point in doing for a HSG because it was there. Here I'm using a 1.9 diagnostic sheet, a 1.9 mm, which is an office hysteroscope, and you can see how smoothly we are going in, no dilatation required, no sounding. And as I enter, this is a septum there. So moving on to the left side, you can see the ostia there on the left side, and we move out and then go on the right side. So both the ostia there. She's not had an evaluation of her tubes because we felt that we're going to give her a procedure. So why don't we combine? In the ideal setting, nobody would do a diagnostic laparoscopy for patency of the tube, but here she is, and we knew we believe in see and treat. We don't believe in calling the patient twice. So here we are. We will be using a 1.9 operative sheet. So I'm doing my diagnostic. After having this view, I'm going to go add on the operative sheet and use the Betoki scissor because this is a septum which is very, very tempting to be cut by a Betoki scissor. So we are just going to withdraw from here. I hope you all can see it so easily seen. You can even appreciate the glands there. And likewise, I'm just moving out, putting the operative channel on this and then moving to do the Betoki scissors guided septal incision. So we can have the light on to show you the 2.9. So this is a 1.9 telescope. Top light on kar dijiye. So you can see this, if you can appreciate that this is a 1.9 telescope to which we are going to convert from a diagnostic, put in the operative sheet through which the side channel which will incorporate. Top light on kar dijiyega. So we are just adjusting the 0, 0 as we do in our alignment to get this in place. Outflow is enough. So this outer sheet has an outflow channel as you have in 2.9 or the 4 mm telescope. We have a side channel, saline. So this is all under, yeah. And this is the side channel through which the Betoki scissors can go, or anything which you want to do, a cannulation or whatever. So with this, we're going to move in and cut this with the Betoki scissors now. पानी ऑन कर देना है जी. Light off. So we are not using an endomat select in this case. We have a hammer on this side. And the advantage of a select is that the control of the suction is in the foot paddle of the operator. Here you have to keep opening and need the help of your assistant to do it for you, or maybe you can do. So here we are. And now we'll be putting in the Betoki scissors to the side channel, which is a 5 French for the 5 French instruments, including the cannulation set or whatever that you do. And so we'll begin. You keep cutting on either side. So not a very big septum, but even the bigger ones can be taken care with a bit of scissors. The good bit of cutting with the scissors is that you're not using energy sources. So the harm is not there. And the biggest thing is that you're working at the senine and the safety margins are very good. So you're very sure that Juhi, I hope the screen is clear. Things are visible there.
Yes, clear.
As you keep cutting, it starts opening up. The cavity is opening up. And I think a point to define is that we keep ourselves around 1.5 centimeters away from the ostia. So this all can be done in office, because it's a workshop. So you can imagine the patient is lying, she gets just a sedation. You can even keep talking to your patient and perhaps give a paracervical. And that's the beauty of using a 1.9. So here we are, we've almost done this with a small septum. And the point of stopping is, as I said, the landmark is just seeing the two ostia at the same time. Or if you come in a panoramic view, you can nicely see the ostia. There we are, we can see the ostia, and we are here. On this side. So this is our limits on the lateral side, and there we go. We are almost done with the septum, which we have incised with the We'll stop here, and that's it. We can go to the second case, Juhi, on that side, and I'll just show you the final view here. Here we go. The septum is all cut, and there we are. We don't need to then go further. We would not do, in an office setting, we would not do a laparoscopy or anything, but since this lady will have to go in for HSG and she's under anesthesia, we're just going to put in a scope in her pelvis and just look for the tubal patency right away, right? So office procedure, simple, quick. I'm sure if you would have done an HSG, you would have picked this septum, you would have done it in office procedure with a very thin and slim 1.9 millimeter telescope with a diagnostic sheet removed, and then we go on for the operative side channel. We'll go on to the next case on that side. That case is Dr. Renu doing a case of adhesion. Do there's an कोई बात नहीं, मुझे ना आदत सी नहीं है बैठने की। मैम am I audible, मीना मैम? Ma'am, we have a question here. Yeah. They want to know that how do we identify the upper limit, like when to stop exactly? In sustain. Ma'am, your voice is not very clear. Just a minute. I think they've switched the audio. Can we please have the audio in the other OT with Dr. Nina? Yeah, can you hear me now? Can you hear me now? Yes. Yeah, see, the best way to take a decision on a septum, no, this. So the best way to check is that on a panoramic view, you should be seeing both the ostia simultaneously, which I did in this case, and that's the best check. Before you start cutting, you should actually landmark yourself. Have an idea how deep you have to go. So before we start cutting, we should be marking up to what maximum limit we will go. with either ways. Either we're using a monopolar bipolar knife or we're using a bitoki, that means mechanical versus electrical. So I had actually seen that I would go up to, 1.5 centimeters away from the ostia on either side. And when I was cutting, I marked that as a limit. And once I was done, the check is that I've reached upper limit is when I'm seeing both the ostia in the panoramic view. That's it. And many times you may make a mistake of going deeper, which happens many times, and then you start seeing the circular fibers of the muscles. That's something which one should refrain from. But the test is that you see both the ostia in a panoramic view. I hope that answers the question. In a single blade mangrove. Anyway, it's okay. We are inducing the patient in this OT. Can somebody show the PPT and tell about the patient? Nina, you could show the instruments. Patient is going to take a little while induced. ऑडियो स्विच कर दीजिए दूसरी तरफ. मेरा ऑडियो ऑफ कर दीजिए. गिव इट टू OT9 प्लीज. लाइट Light is not an issue. Okay. So are we there from OT9 here? Okay, so we wanted to show you the instrument of a 1.9 millimeter. So here I would show, I hope it's visible nicely. So we are showing the instruments and the equipment that I used in this case of a septum. So we want to show you the 1.9 millimeter telescope. You can see how thin is this. It's so sleek. The beauty is when you're doing infertility, ARC, all the procedures, you want to be as minimalistic in, harming the cervix or going in. In fact, this has been designed by the Karl Storz for a vaginoscopic approach. That means it's a no-touch technique. So this is exactly the 1.9 millimeter telescope, which is one of the slimmest and the thinnest, and even part of the Camper Trophy, which is a 1.9 millimeter telescope, which is one of the newer editions by Karl Storz. I know that Karl Storz are leaders and they are the best when it comes to the telescopes and hysteroscopies, and of course the patents of the Betokis and all the scissors are there. So this is the Karl Storz telescope that you can see. Now, for the diagnostics, this is the sheet that I have, and this is what I will use when I'm just doing a diagnostic. So you can see how easily it is, again, very sleek. So when I assemble it, the same principle, the 0-0 alignment, and that's what it locks, right? So it fits in so well. We get the 0-0 here as we do, fitting it, locking. Now this is all the assembly that I need. I'll attach the cameras on the top there. We'll attach our camera, which is a 2D camera, and that's the light source getting connected. And while we're doing a diagnostic, this is the inflow channel, the saline. So if you have Endomet Select, fine, but a diagnostic like this, even if you don't have it, you can use it at whatever system that you have. But we certainly prefer, when it is safety, the Select, because it is a very good sensor system which actually looks in the inflow and then defines the outflow. So the real challenge that we have in hysteroscopy of fluid overload is totally obviated. So you can see how much safety precautions the new Endomet Select has. And also, as Dr. Renu had told, the foot paddle, the control is under the feet of the surgeon. So he or she knows how much to go in and out. Now, this is what we have a diagnostic. Now, as we do the diagnostic, we put in the telescope right when you went to the septum, and when we identified, I knew that I can tackle this with the same, sitting. I can go ahead and we do C and 3, we changed this and went on to do a operative. Now the operative channel here is this, what you can see is it's got an inner and an outer. So this one has got inflow as well as the outflow, which will come in the out sheet here, right? So this is the inflow. This is the site for to put in the 5 French instruments, including the Betoki scissors or the cannulation set. If you want to do tubal cannulation, we have one case for you. We will show you that as well. And we will use entirely with our 1.9. Now here I go. I enter again, use my formula of 0, 0 alignment, and I lock this. That's the lens assembles, the telescope assembles. And because I need the outflow as well for a procedure, because this was short, didn't need much of fluid, exchanges. But somewhere we may need it longer, and of course we should because the safety issue is there. I'm just putting in the outer sheet here, which is again having a 0, 0 mark, and we enter. So here we are aligning the 0, 0 here again, and we are just locking this, and this is exactly the entire assembled set. You can see how sleek this is. No dilation, no sounding, because once you've done a diagnostic, you know the direction, you know the passage, and this is it. So just a few millimeters more over the diagnostic. So there's an outflow, that's the inflow, and that's the side channel. That's the light source. So with this was the Betoki scissors. I know it's a very delicate instrument, but such a handy tool. It works wonders when it goes in for a polyp, for a septum, and I think for adhesions is the most brilliant, for an instrument that we have. So here we are with a 5 French going in. We put it in through this. So there we are, and we work on it, right? You can see how brilliantly it works. You cut in, move your light sources, and there you are. I think we'll go on to the other side now. They should be ready with the case on that side. Okay, so while the patient is being induced, we are going to assemble the equipment. I will show you the basic endoscopy equipment. Has somebody shown the PPT of this patient? Okay. So you want me to tell about this camera, and or you going to show the PPT? Okay, then somebody has it on their phone, the PPT. You can just show it here. No, the PPT. Okay. So anyway, I will just show. So I'm assembling my camper trophy. So like this whole thing is one unit. Like I said, there is no separate diagnostic and operative sheet. So I have assembled. This is the sheet. This is the outflow, and this is the inflow. Now the trick to remember is that whatever is closer to the surgeon is always irrigation. No matter what scope, what company, this always holds true. So you don't have to keep looking. And if you put it the other way around, then you'll be in big trouble. So what is closer to the surgeon? Can you see? So this is the irrigation because this is closer to me. And this is suction. This is the outflow. This is inflow. This is outflow. So I've connected that. And then one end of the tubing is coming here into my scope, and the other is going to the suction bottle. So that completes the circuit. Now, before starting any endoscopy, whether it is hysteroscopy, laparoscopy, you need to put your camera, and then you first focus, and then you do white balance. That is a very, very standard thing, whether you do any endoscopy. So you first focus, get the best focus. So that looks good to me. And then he's done the white balance for me. You could also do the white balance from the buttons which are provided on the camera head. But basically what you need to understand that you first focus and then you white balance.
And also, because the scopes are delicate, sometimes if it is difficult to focus, then somebody should hold the telescope here at the end, because otherwise it keeps wobbling and it's difficult to focus. So it is focused now. We are focused, white balance, we are ready to go. Just waiting for the patient. So the making it back into a diagnostic sheet, I'm bringing back my operative sheet. So this is now 2.9, but the length is 2 millimeters, and with the irrigation sheet, the whole assembly now, the diagnostic tip here is 2.9 mm. And with the sheet for introducing the side channel, the instruments, it becomes 4.4. Okay. Bolo, acha nahi tum nahi bol sakte. So this patient is 31-year-old. Can you show me the PPT? I will just read it. 30 मुझे दिख नहीं रहा, चश्मा लगा तो मेरा, सॉरी, एक फ्री माइक रखना चाहिए था ना यहाँ पे, कोई ऑडियो, तुम कैसे रीड आउट, तुम्हारा माइक नहीं है ना माय डियर? हाँ प्लीज करो, बोलो, पढ़ो. So the next patient is Mrs. X, 31 years old, with history of recurrent pregnancy loss, and then her LMP was in 23rd November. Otherwise, she has regular flow, and she's previous to abortion with both the first trimester abortion, and history of multiple cycles of ovulation induction for the second fertility. Otherwise, her examination, general examination was unremarkable, but her HSA, other infertility was reported unremarkable. HSG showed irregular outline. So HSG showed irregular outline. I'm sharing from the Zoom platform, so I'm not able to show you the conference call. It showed irregular outline of endometrial cavity. It showed a history of thyroid lesions. So there is an ultrasound also, and there was a little bit like irregular endometrial minor that infection. So here we are going to going for diagnostic hysteroscopy and plus minus administrative. Yes, yeah, okay, we're just painting, draping the patient. If there are any questions in the chat box or anybody, we can take the questions in the meantime. Yeah, because while we are waiting for the patient to be painted red, we can always utilize this time if there is anything. When we do diagnostics, you can put in a speculum and hold with an Alice. I don't like Valsalum, because Valsalum is very traumatic. You don't need that kind of force in hysteroscopy. So best is to use a Alice forceps. Of course, surgeons have their own choices, but that's what I prefer. So hold. So you can either put your telescope under visual guidance. That means while you're looking through the speculum, or you can go into the uterus vaginoscopic, which means that you put your scope into the vagina, turn on the water, and then you guide visually as you enter. So you guide yourself into the external os, internal os, and enter the cavity. The advantage with that is more in office hysteroscopy, because when the patient is anesthetized, it really doesn't matter whether you go vaginoscopic or not, because she's not going to feel anything. But if you are doing a hysteroscopy without anesthesia, it makes hell of a difference. If you don't put the speculum and you just go in with your scope, patient has minimal pain or discomfort. Because the minute you put a speculum, patient gets apprehensive. And when you put the scope in, so it is something like 3 millimeter going into the vagina, she obviously doesn't feel anything. And once you put water inside, and again, if you navigate under vision, then even going through the internal os with a thin scope is quite, very, very little discomfort she gets. So it is important, if you are going to do office hysteroscopies or hysteroscopies without anesthesia, office or not, then it is good to learn vaginoscopic approach. It takes time. So you should start with the standard by with holding with a tenaculum or valsicum with a speculum, and then gradually you can progress to doing vaginoscopic. To do vaginoscopic, it is very, very important that you get proper training how to navigate the hysteroscope. Because if you're not going under vision, then you cannot do vaginoscopic. A lot of people who are not really trained properly, they put a hysteroscope like you put a curette. So, they just insert, and obviously there's the opening, the hysteroscope will go in, but that is not the proper way of doing hysteroscopy. You should always go under vision, vaginoscopic or not, but vaginoscopic, of course, you cannot enter if you have not gone in. We don't need really. Do we need a pocket? चाहिए हमें क्या रखेंगे pocket में? Don't need a pocket in hysteroscopy. Okay, something which I wanted to show you, just a second. Do we have a plastic sheet? मुझे एक दूसरी वो दोगे, एक दूसरी शीट दोगे, हटा दो. Put just simple sheet here. ऊपर एक वैसी डाल दो. So something, is my external camera on? ये तो बहुत छोटी है. Anyway, I just wanted to show everyone that for diagnostic it is not that important, but then when you're doing operative, obviously the fluid balance is so very important. Common complications are fluid overload. And how do you make sure that all the fluid that is coming out is accounted properly? So you can have, there are very fancy drapes which come for hysteroscopy, in which you can attach a suction and everything collects in a pocket and you can measure that. But in a country like ours, where patients, of course, in government they don't pay, but in private they pay for everything, you have to think how can you make the procedure more cost effective. So what I do, I put a drape below, which is non-absorbable, so the whole water goes into the bucket. Make sure that the bucket is empty so that whatever water spills into the bucket can be suctioned out. So that is what you do. You can get a hysteroscopy drape, like I said, but you could also do with a more ingenious things. ये टेबल या तो नीचे करें या मेरा स्टूल ऊपर करें. हाँ, फिर भी स्टूल थोड़ा ऊपर कर दें. हाँ, थोड़ा सा ऊपर. Okay. So we are all set to go. So let's check the water. You need to see the water pressure before going in. Okay, the other little things that you need to learn, especially when you're going vaginoscopic, that it is a 30-degree scope. Is this a 30-degree scope also in Camper Trophy? Okay. So it's a 30-degree scope, which means that when your light lead is down, then you're actually looking up. So it is important because you can only navigate when you know where to keep your internal os when you're going in. Let me see the pressure. The pressure should, yeah, that's good pressure. So if you have a forward, going projection of the water, then you know that pressure is good. Yeah. So, but bubbles also, get generated if the endomat is giving a little shaky sort of. So we make sure that all the bubbles are out of the system. Okay. So this is, we are going vaginoscopic external camera. You don't have to hold the vulva. No, you don't need to hold the vulva. So basically, this is the vagina. Target the posterior fornix when you're going vaginoscopic. Go into the posterior fornix. Although this lady has a lesion, sometimes they are more difficult to do the vaginoscopic. So that's the posterior fornix, and then we try and find the os. cervix. We're going all around. Still trying to find the os. I have not seen. थोड़ा सा टेबल और नीचे कर दीजिए प्लीज. If I cannot see it with vaginoscopic, then I will go with my speculum. I have not seen her per speculum before, so I don't know whether it is a pinhole os or what kind of os it is. But I'm going all around and I'm not able to get into the os. That's the cervix. Maybe we do a per speculum and then we go in. Patient with adhesions may not have a os which you can negotiate without speculum. Although I'm still trying. One trick is to look for the betadine. The mucus in the cervical canal usually will get stained, and that is one guide to the os when you're doing vaginoscopy. I really cannot see the os. But the os to make it come. But you see, this is where I am deep into the posterior polyp. ये तो posterior vaginal polyp. मुझे लगा कि शायद ज़्यादा नीचे तो नहीं है. कई बार sometimes you think that you are right below. Again, otherwise it's a very tiny cervix set. पानी का प्रेशर ठीक है? She's not had any pregnancies, is it? Yeah, I cannot find this cervix, so let's put a speculum. Let's not waste time. Okay. लाइट पीछे लाइट दीजिए. ओटी लाइट देखते हैं. पकड़ लेते. जब हमने डाल ही दिया स्पेकुलम तो फिर पकड़ लो. उसका एडवांटेज पूरा ले. Okay, so that's the os. Now you can see. We are just पीछे की लाइट ऑफ कर दीजिए. So we are just in we're just inside the external os. You see the cervix intracervical arbor white beautifully because this is under magnification. And then now you have to see that with your light lead down, you have to actually so you have to see that this should be at 6 o'clock. It should be here at the bottom, like making a semi-lunar the internal os. Then you will go in without touching anything. You will go absolutely smooth. Oh, इसका क्या है ये? Lesions है? Very interesting. तो पूरी caves हैं. अजंता एलोरा की. बहुत interesting है ये तो. ये तो सच में है तो adhesions, but इतने thick adhesions हैं. Such thick adhesions. पहले लगता septa है, but then there are many. You can't have septa like this. Okay, all right. Yeah, but such thick septae and so many. Very interesting. Okay. So, Richa, put the scissors. So you see now I'm going to just push this in. That's the advantage of campotrophy, that I'm just going to push the poke in. The advantage with this is that I did not have to remove my assembly and I can just go in straight away. Yeah. Inside, I just check. Okay, yes, now it's good. So, scissors is, the best. I used to do a lot of resection TCREs, but now as you get older, you find that non-energy sources are better, safer. And if you can do it with a scissor, why use current? Is the picture clear down there? Are we on the endoscopic mode now? Picture कौन सी आ रही है? बाहर की कि अंदर की? See, scissors are so good and so safe. It will cut only what you will want to cut. Whereas with an energy source, sometimes if you're not careful, it can cut much deeper than what you want to cut. So that way scissors is really good. The only thing is you should have a good scissor which cuts. Sometimes you have non-cutting scissors which really make your life difficult. So imagine this patient would have never conceived with this. And with a hysteroscope, how much does it take? 10 minutes. See how the adhesions are going. So it is something that every gynecologist now needs to learn. There's so many intrauterine pathologies which have major consequences, which used to be major surgeries. Now you see how beautifully you don't have to injure anything. You just go in with your scissors. Udhar patient use kara do, please. We are done. You see how much it takes. And if you have a thin scope like this, you can even do without anesthesia. Just give her some painkiller, not even probably sedation. Actually, there's nothing more to do. Look at the cavity now. It looks pretty normal. It is generally the endometrium is also thick, which might be depending on what phase of the cycle. That is the. So if you see now, this is 30-degree scope. And if you have to see the left ostia, I need to turn my light lead to the right. It has to be on the opposite side. Those who are for physical in the hall, in conference hall, can actually try on the endo trainer. The histo trainer is there and you can learn how to navigate. And now I'm taking the light lead to the other side and you can now see the right ostia, which is little bit more deep. देखिए लेकिन मैं ostia देख सकता हूँ. Adhesion to it नहीं दिख रहा है वैसे ही. Focus on the line. Please show the hysteroscope outside. Okay, I will show you again. Just 1 minute. थोड़ा सा है दीदी. सिर्फ एडिशन की बात है. एडिशन इतना नहीं है. बाहर वाले पे फोकस करिए. So I will show you again once you have the outer picture. Just let me know. You got it? दोनों तो पीएनपी पीआईपी कर सकते हैं क्या? किया हुआ है. अभी दिख रही है तुम्हें दोनों? अच्छा. So basically what I want to show you, this is basic of hysteroscopy that you need to learn. कि light lead जब नीचे है तो आपको ऊपर दिख रहा है. You are seeing the anterior wall. And when I take the light lead up, then you actually see the posterior wall. So see, there is another adhesion here. So this is okay. So that is good. So we turned and because this was looking like a polyp when I just entered, but it is actually a adhesion. Thoroughly enjoying. Yeah, I'm also enjoying because I didn't really think that I will have such neat adhesions, to cut. Normally it's a messy thing, but these are beautiful. Nina has kept such beautiful cases. That's the advantage of operating in AIMS. You get the best cases. They have so many cases that they have the privilege to choose. Whereas in private, you have to just keep whatever you get. You don't have such queues. Maybe a teacher. Maybe a teacher. कैसे इसके बन गए? अच्छा डीएनसी. ओके. कोई अबॉर्शंस में कोई नहीं हुआ है डीएनसी? क्या हुआ? नहीं मुझे 1 डीएनसी ना. See, I was just reviewing, 1 in 5, 20% patients develop intrauterine adhesions after DNCs for abortion. So it is very important that we should not do just DNCs left, right, and center. And wherever you can manage the patient medically, please do that. That should be the message. बहुत ही सुंदर है नीना. So pretty. मतलब adhesions इतने सुंदर कभी नहीं होते. This is actually a polyp. So I'm just going to cut it and come out. ये बैंड नहीं है, ये तो पॉली मतलब बैंड का ये क्या बोलते हैं पॉली, वैसे सारा ही एंडोमेट्रियम इसका पॉलीपॉइडल है. ये से क्या होता है रिसर्च करें को ये कह रही है. I mean, it's been like it's a possibility to extend testing to Dr. Mahavi. Welcome, Maruti. Good morning. This was a very interesting case, adhesions, but the whole actually endometrium is polyfertile, so it's bleeding a little bit now. But I thought I will cut this also with the scissor. The scissor is cutting beautifully. बहुत सुंदर है, नया है शायद. Thanks to Carl Stores people who are providing us this equipment. See these, when you do look at this bleeding, and when you do actually ultrasound, then that is how you differentiate sometimes between polyps and just thickened endometrium. That you can see a dedicated, vessel going into the polyp. Although of course, if it is, इधर का patient induce हो गया? हाँ. ये तो see when you do curettage, you cause much more injury and much more bleeding, and you never actually bother to do anything, isn't it? So this is definitely doesn't need to worry you. So we had, so now are we still on PIP? अच्छा, so ये मैं दिखा रही हूँ कि आपको कैसे 30 degree scope है. So when you turn this to my right, then you actually see on the opposite side ostia. So it's like diagonal, cross करते हुए दिख रहा है. So that's left ostia, and it is the lead is on the opposite side. When you look at the other ostia, the lead is to my right now, and I'm seeing the patient's right, but which is left for me. So opposite side. So this is the ostia. So Richa is scrubbed with me, and of course she is also very experienced. And she was telling me, ma'am, you can't see this ostia because there is an adhesion. And I must say, I found that as soon as I turned the scope, because I was saying, no, it is just a deep ostia. So Richa, you are right. Just hold my lead. I'm just going to cut a little bit here also, since there's nothing happening with the other machine. Let's just cut this. This is a sessile polyp. If you just had this polyp, single polyp, then you can cut it with a scissor and then you put in a grasper and take it out with a grasper. Or you could just put in a curette. But if you take it out with a grasper, then you know that you're exactly holding that tissue which you want to go for histopath. Because it actually depends how much do you want that particular tissue to be sent. Of course, it will come out in. See, you have to see. I need to change my. I need to change my vision to see the scissors. I'm actually just making. I'm just playing around with this polypoidal endometrium till we are ready to start the case in the other way. अच्छा उधर लैप्रोस्कोपी हुई है. अच्छा तो क्या आप यहाँ दूसरा लगा सकते थे. इसको ग्रास्पर से भी दिखा सकते हैं. So actually, if you want to remove a polyp under vision, then best is to leave it little bit attached. Otherwise, it keeps floating inside the cavity. So I can actually now put a grasper and bring it out under vision. So the brasper is going in, and see some bleeding from the, because it's a very thickened endometrium. Where is my polyp? This is the polyp. So I can actually hold this polyp and then twist it off from the base so that it doesn't float away. And then you will have to remove the whole scope. You have to take it out. So before I remove the scope, I will just show you once the cavity that
ऑडियो भी गया
so it is clearing out. So now you see, I think if she has no other problem, she will actually conceive herself without anything, without ART. I don't know the rest of the history, but it's probably these adhesions after the first miscarriage which have caused so much havoc that she hasn't conceived. Okay, so I'm going to come out. And when you're coming out, you actually look at the cervical canal while you're coming out. There is a little bleeding. Okay, there is little bleeding now because of these which I've cut, you know. थोड़ा सा suction और irrigation दोनों बढ़ा दें. थोड़ा सा बढ़ा दीजिए pressure तो मैं इनको दिखा सकती हूँ. Irrigation बढ़ा दो. That I showed in the beginning actually, Maruti. But anyway, now suction हो रहा है. Okay, ठीक है. हाँ, okay. थोड़ी सी bleeding हो गई इसलिए इतना panoramic भी अच्छा नहीं दिख रहा है. But this is sitting at the internal os, and now you can see that it's the entire cavity. And so there is nothing now in the cavity. There were 3 bands of adhesions, but it is now absolutely clean. So this is 1 band, and there were 2 others which are now cut. That's it. वो ब्लीड कर रहा है ना एक्चुअली, ये जो जहाँ से हमने पॉलिप्स काटे हैं ना वो सब में वेसल्स होकर ब्लीड कर रहे हैं बिकॉज पूरी ही पॉलीपॉइडल है इसकी एक्चुअली एंडोमेट्रियम. It is not just discrete polyps. So that's the final view, and we come out. That's the cervical canal. You can have a good look when you are coming out. Keep these internal os now in the center instead of keeping it 6 o'clock, and then so that you can have a complete view of the cervical canal all around 360 degrees. Okay, so we are out. Get you? Any questions on equipment? Anything about the procedure? We've got 5 minutes before we start the next case in the next OT. So, if there's any query, we can talk about it. Anything on the chat? Anything in the hall? Yeah, go on. Yes, yes. I'm not aware of anybody injecting vasopressin, although people have started injecting vasopressin everywhere. In fact, I've heard more of intracervical, vasopressin, because most of the time these are not very vascular. It's fibromuscular septum, and of course the amount of muscle and amount of fiber. Nina, somebody is asking, can we inject vasopressin into the septum? तुम्हारी आवाज नहीं सुन रही? Your voice. Yeah. So, दूसरा कहाँ है? अच्छा, doctor. Yeah. Right now, नहीं वो भी ऑन ही नहीं है. Yeah. No. As such, septum injection. Yeah, that's what I said. And like I said, but some people are injecting vasopressin into the cervix. I don't have any personal experience, but I know that some people are doing that. So most of the time it is not an issue. So because you can use a cautery if it is vascular, but I'm aware that people are injecting into the cervix.
And in fact, during the office also they use vasopressin in the cervix. They say that it reduces the blood loss when they are doing a kind of an office. They do inject the cervix.
A few more questions.
Yeah.
In the chat box.
Not 150.
No, the question is if the irrigation pressure is set as 150, what is the intrauterine pressure? If they want to know how
Okay,
does it
okay,
work?
listen. This is the intrauterine pressure that you're setting. It is not that the pressure, I mean, what other pressure can we set? We're talking about the intrauterine pressure. If you're setting it at 150, then you are actually pushing fluid under pressure into the intravascular compartment. Because like I said in the beginning, if your blood pressure is 120/80, that means mean arterial pressure is around 100. So if you keep it 150, then you're pushing it forcefully into the intravascular space. Now, how much it will absorb depends on if you're opening any vascular sinuses, particularly. So if you're doing a myomectomy, if you're doing a TCRE, then the chances, the fluid overload will be more because you're directly pushing into the vessels. If it's a polyp, which is not generally very vascular, then you would still be pushing more fluid into the abdomen if her tubes are open, but it is not so much direct intravascular. So it is not a good idea. I know that Dr. Shoki recommends very high pressures for hysteroscopy, but I have never read or in any guideline where anybody ever recommends that you keep such high pressures. You probably have to be very, very quick. So somebody like Osama Shoki may be doing it so quickly that patient doesn't have a problem. But logically, it doesn't make any sense to keep pressures at that. If you keep your pressure too low, then also it's a problem because then you will see pools, blood coming through, like you saw in the base of the polyp when I was cutting. Then you would see bleeders, coming down from the endometrium. So the pressure should not be too low also. Ideally, it should be just enough that you can see inside and that there is no bleeding. That should be the pressure. You don't sometimes need even 100. And there's another thing about pressure. Suppose you have a submucous myoma, which is grade 2, let's say, which has a very small component inside the uterus. If you keep the pressure like 150, 200, you may not see the myoma. It just completely flattens out. So if you are actually doing a hysteroscopy to assess, sometimes, we have patients with fibroids where you have to do IVF and you are going to do an embryo transfer. So you certainly do not want to do an embryo transfer if there is an intrauterine lesion because patient may still get pregnant. I mean, it is not 100% that she cannot conceive with a submucous myoma. There are studies, but obviously the chances would be less. So no ART clinician would want to do a transfer where there is an intrauterine myoma. So you do a 3D, 2D ultrasound, which gives you a fair idea how much is the fibroid is cavitary and how much is intramural. But seeing is believing. And for an IVF patient, I would not just only depend on that because here, to me, it is crucial that the cavity is clean. So if in such a pressure, you are going to put a scope in, you may have the pressure like 100, 110, 120 to inside, when you go inside and look inside all around, but reduce the pressure and suppose you don't see a myoma, reduce the pressure and then see. So many times the myomas actually are visible when you reduce the pressure because very high intrauterine pressure just flattens out a small myoma. Even if you see the myoma, reduce the pressure to see how much of it is intracavitary. Because again, if you can see it intracavitary, but if the pressure is very high, it actually gets flattened out and you get a wrong sort of feeling. You think, oh, it's just about pointing inside the cavity. You reduce the pressure, you say, oh no, it's a good 1.5 centimeter jutting inside the cavity. So that is about pressure.
They want to know that after adnexiolysis, what is the measure that we take to prevent further adhesion?
There are a lot of studies, people have used a lot of things to prevent recurrence of adhesions after you do adhesiolysis. So first of all, I will tell you what you should not put. So copper T is not to be put because that copper causes inflammation, aseptic inflammation. In fact, that is one of the mechanisms how it provides contraception. But here we do not want any inflammation because that will cause more adhesion. So copper T should not be put, number one. A levonorgestrel IUS intrauterine system like Mirena should not be put because that makes the lining of the uterus thin, which will again, give a sort of increase the risk of adhesions because it is so thin. Just the basal layer is left; the rest of the endometrium is not growing. So these two are not to be used. You can use an inert IUCD, which we don't get actually. So earlier, I have also not seen in my lifetime, people used to put Lippy's loop. That was good because there was no copper, it was just the loop. Some people say remove the copper from the copper T and put it. Well, that is something you can do if you want. But there is not, very good evidence to say that it helps reduce adhesions. Then you can actually put another mechanical device like a Foley's or any balloon catheter which will keep the surface apart. Or you can, if the adhesions are not too bad, you can, and if the adhesions too bad, then with the Foley's also you should give some hormones. The idea is to give a little boost to the endometrium lining with estrogens so that the endometrium grows and quickly, covers the bare areas. Because if the adhesions are thick, then they may be extending up to the basal layer. So you want that wherever you have cut, and if you've denuded some part of the endometrium, it should be, quickly epithelialized. So you can give hormones, and you can put a Foley's and leave it for some time. There are people who leave it for 24 hours. There are people who leave it for a week. There is no standard recommendation as such. But these are the two alternatives that you can do depending on how much is the adhesion. If you can see the entire cavity and, if you see the kind of bands I was seeing, I really don't need to give her anything post-op because the cavity, I mean, those adhesions were not going deep. In fact, fortunately, they were just sort of going into the superficial layers of endometrium, and the whole uh, endometrium was already very polypoid. If I give her hormones, it will become even more thicker, which is not a great idea. So this lady actually needs nothing, to be honest. You people who are in the hall, if you, in the meantime, when there's nothing happening, if you all want, Dr. Maruti can take one by one or take you in groups of 2 or 3, depending how many people are in the conference hall. And you could actually do a little practice on the pelvic, the hysto trainers, and learn how to negotiate the hysteroscope under vision. That is, if you know how to navigate the scope, that is half the battle won. Because if you're going to put it like a curette, then you are going to scrape the walls. You can't see anything. There is bleeding. There is, all these endometrial fronds in your way, and then your whole vision is gone. Endoscopy is all about vision, how you can keep your vision clear. So if you have time, then you can utilize the distro trainer and learn how to navigate. Does, I'm just going to peep into the next OT and see. Inducing the patient. And what is the patient? We can start telling about the patient. Can you please switch the... Yeah, and can you switch the audio to Dr. Nina?
Yes, ma'am, connected, ma'am.
It's not. she only had cosmetic. She had a but this was the capability that was greatly so immediately focus my 3 years in that year. So otherwise the level examination was underwhelming. On investigation, again, like what I made in the floor. And in ultrasound, you could see very thin fundamental lining, just 3 mm. And in 4D ultrasound, you could see thick legends, and illustrations of plasticity. And this was a scenario. So we thinking that she has lesions and attachment, so then we focus like 3 years.
Yes, hysteroscopy only. ये रखे रखो, you may need it. जूही? No, no, I don't think. पहुंच नहीं रहा हॉल में. On है? नहीं, मैं तो I'm on. Maybe we are not connected. White balance. इसका सर्कल भी बढ़ा दीजिए, इसका भी मैं बढ़ा दीजिए इसका. It's from your end. हाँ. We are just going on with the case that you had given the clinical history. Just doing the white balance here, and again I'm going to use a 1.9 millimeter telescope. This lady is I think severe adhesion. Okay. You can show the. Are you seeing us or you're hearing us only? So this patient, I think you already given the background of her clinical story. You already told her story. You have told to the audience, I'm sure. Do you have you describe this patient? Okay, so she is a lady who has had a previous diagnostic hysteroscopy in the past and laparoscopy also in 2012. And then she has scanty periods. We've done a scan, Pani on Kartijaga, and the scan actually she shows or a 3D imaging areas of calcification and suspicion on of adhesions in the cavity. So we just want to go and just see how much can we do, because calcification spells a major degree of adhesion, 3 or 4. And this lady is actually for a donor oocyte program. She's got low AMHs, but the subject is how much of the soil we can create. That's the issue. So I'm really skeptical whether really we'll be able to do some good job. But because at the end of the day, it's not creating a cavity, it's looking at a healthy endometrium that we can get. If there are few violins of healthy glands, can we give her estrogens, to what limit? And so we are entering in here. I anticipate that the entry would be not all that smooth. Yes, so I will actually wait for the cavity to slowly distend, right? So can you see us here? We are right in the cervical canal, see, and you can see that this is an area. So I have to really know where I'm negotiating, because I can go and create a false passage as well. So we have to be patient. Follow the water. That's the rule I do. They come out, see for the turbulence, see which side the water flows. You flow with the water. That's exactly what it is. So I would put hysteroscopy as a game of patience. If you're patient, you'll make it. If you're impatient, you may not. So I see these glands there. And many times, the water, which is I consider water the best dilator. It does you more good than you can even think of. So here we have adhesions here. We'll probably snip off this as well, so that maybe this will open up the cavity a little. I see a hole there on the right side as well. So maybe we can prognosticate her whether she merits hysteroscopy or she actually, is left side. Madam is right now, right. Chalo, now I think let's cut this adhesion and then see how we can go. This is an adhesion right at the internal loss. So we will convert this 1.9 diagnostic. We'll put an operative sheet on this. I'm kind of using this as a negotiator and trying to find out my way, maybe creating my passage. And another trip, we'll just show you, even if we don't, I believe in after doing a lasers of furrowing the lateral edges. This was a brilliant journal club which Pankaj presented. Dr. Pankaj is doing DM, actually presented a Chinese, study, a large study. It said that even if you cut the edges, you furrow the edges, which we do, but it's just like these are these edges. So here I am, I've entered, and I think this band still persists. So I've moved a little deeper, and I can get an orientation which is much better. The good bit is you can see that there are some vascular patches which actually spells a good prognosis. So I'm still in the canal. I've not really reached up. So we'll go ahead and put in the operative sheet on this. Light on kar dena, please. ऊपर का light on कर दीजिए, please. मैंने लेंस रखा हुआ है टेलीस्कोप, ये ऊपर वाला काट दिया. पानी बंद कर, पानी बंद कर. I'm just using 1.9. I think after the 1.9, I believe everything is possible, especially when it is ART infertility. We just stick on to the 1.9, it does wonders. So we are just converting and adding the operative sheet with a side channel through which the Betoki can go the 5 French. And so we are just attaching the camera to this. I'm sure it's visible there. What we are light on, white balance. The lens to the back. I think it's up. The camera. Wait. Right. Then he persists क्यों कर रहा है? आ रहा है. How to let go? How is it? There is a area on the camera is clean. Camera किया है, but we just clean it well. Take out the telescope. Yeah, there's a bit of water on the lens. That's probably causing it. So, these are the things that you should ensure that you have a nice view. Funny attach to it. Just touch water. Water on. Where is the funny answer? we've entered here and we're trying to kind of negotiate and see how we will be able to make it into this useless. Yeah, there we are. It's a completely occluded affair. I'm still not entered. I'm just trying to negotiate myself. Yes. I'm following the water. That's exactly what it's supposed to be. See the flow water. Section on. There I am. Okay. So is the view there? You can see. So there we are with that transverse band, which you can see is stitching and bridging the anterior-posterior wall, and then these are the edges that we have. So we'll start cutting and see where we can make it, how much we can make it. So I just see that you can have a look at the endometrium all around. It's all atrophic, you know. There are hardly any glands, right? So we'll cut through this band and then we'll see how we can move further. Yeah. Yeah. So I will just go slow. I think this is pretty low down. It's just at the surface. That is go slow because the Vitropy is a very sharp instrument. You have to have control there. It looks small, but it does a lot of job there. Right. So these are all the patients which are fibrous. And as I'm cutting, you can feel these are a little kind of calcific kind of bands. You can feel as you cut the kind of grating that you get, it's like it's a gritty cut rather than a fibrous cut. I'm feeling I'm cutting on a very gritty kind of an affair. So yeah, so I think I would say, for anybody who is trying to do hysteroscopy, 3D, 4D is such an asset. So it's like, it really tells you to plan yourself. I would say it helps you Google your, yeah, it is actually a virtual hysteroscopy. When I would call it in terms of diagnostics, you can diagnose so much. So it's a completely occluded kind of a cavity. Yes, you should do it in a laparoscopic guidance. But here, you know, I really would like to see how much we can cut, and we'll put in a scope. Uh, Slowly, we just want to see. Yes. Rita is all ready here to sort of help me whether we have to. We were kind of debating, should we put in a scope or not? Here we are. So we're going to move gradually up. I'm just wondering whether we can really, even if we create a cavity, can we give back a soil which will be actually, but then it's not that for the fact of a laparoscopy, is basically as a kind of a guidance that I know where my safety limits are, because when you do an addition like this, you have a big risk of perforation. So the dual system, you know, actually tells us our limits. Kind of furrowing to see if I get some glands beneath, because I'm seeing some vessels here. I'm trying to open. We'll go slow again here, and we certainly put in a scope to navigate us on our upper limits, because I really don't see a very good prognosis for this lady when it comes to putting an embryo from whatever source we get, whether we get it from a donor or it's her own autologous oocytes. You can see as I'm just cutting through a gritty kind of a plane, and then I'm hoping it's opening up. Just some hiding settings to show them the. So Rita has just waited for me. She's coming. She's going to put in a scope on the top, because that will help me know how deep I can go. Even at whatever stage you are, you still face a risk of perforation. So as of now, I'm doing it with ease, because I know that we are. But yes, in an ideal setting, yes, we should always do all these adhesions under this kind of adhesion certainly. So you can see wherever I'm cutting, I'm getting a very gritty calcific feel. So really, truly, this adhesion is a challenge. So, you know, challenging and exciting for the surgeon, but for the patient, not very nice, because this does not spell a good prognosis. See, I'm just kind of knocking, I would call it my knocking technique. I knock it and I feel which is the place I can go. Can you see that? I'm just knocking around with the tip. That's creating some gaps for me. I can just feel I'm going in. I tap and I knock and I see how much can I cut. So in severe adhesions, that's the way that's the trick. I move forth and back and forth. Again, gives me some bit of leverage, because the scope itself is kind of, but such adhesions would not come through with a scope. They are severe adhesions, the flimsy ones too. So she had adhesions even in her abdominal cavity on the previous findings that she had in 2012. So you can see, Dewey, that we have moved further. See, I mean, I was just at the os where I saw nothing, right? I wasn't able to, but here we've been able to go into the uterine pouch, as I would call it, not the cavity, because there's hardly a cavity. So where I had such challenge to even sort of see the canal at the cervical os itself, we made some headway. We have kind of, so this is the way the internal os, and I've been able to move up. So again, the choice, I think when it is grade 3, grade 4 adhesions, the wisdom, my understanding is use the Bitoki, you know, energy sources. Maybe somebody is comfortable, but I think Bitoki does more wonders. You can see I knock, I tap, and then I cut. So I just knock, tap, and cut. That's what I think helps you. So Rita's going to put in a scope. I'm going to stop here to show how we can navigate ourselves. Just going very slow, unlike the septum where I just zipped off. I just went cut, and I was there. I'm literally being very patient. As I said, hysteroscopy is the game of patience. You have to be very patient. Understand the tissues and then cut. Rita. Yes, yes. So, Dr. Renu is starting to do a myomectomy, and that is with a with the 2.9. So I think we'll just put in the pneumo, and once he's done, we'll come back here. So, I'm sure you've got a bit of understanding, and in between we'll come back, show you. So, show, okay. So, camera एक ही है मेरे को ऑफ ना नहीं जूही सुनो हम लोग मैडम इज गॉट आवर पेशेंट इंड्यूस्ड so I'm going to keep cutting here. I'm just you like to see this, okay, because we thought you're switched on that side. So yeah, so I'm just cutting through this scar tissue. Can you see that? So Rita is putting in. Again, your wisdom, I understand that putting in a scope would actually help somebody who's I don't say I'm a very experienced surgeon, but normally in such cases, we don't really put in. I think that's what me and Rita were debating. Should we put or not put? Rita was also reluctant because we normally do away our adhesions without a scope. But here we are doing a workshop, so we thought we will show people what is the benefit of a dual system where you can see the translucency or whatever the light test or whatever illumination test as we call it, right? So we're going from here again, furrowing again from the side. Okay, sorry. Oh, you need the cam. Okay, there we are. Can you see the screen there? We are on the side. There are bad adhesions right at the entry point. Can you see the adhesions where Rita is entering into the pelvis? Yes. So I think this is, yeah, there is absolutely, I think, have that camera. Yeah, since she's entering through adhesions, there are all kinds of peritoneal adhesions as well. I'm sure she would have had tuberculosis. Yeah, she's in. Oh, so yes, this is a lady. Yeah, I know we have 3 adhesions today, so I'm good. Yeah, so this lady already has, histopathology proven granulomatous endometritis, and she's had a digital she's had AGT. So, these patients, it is not a good prognosis. So I think we have to spell the fact that, she's better off with a surrogacy because this uterus, no matter what we do, we will not get endometrium. Yes, the answer would be stem cells. I'm sure Rita is really pointing out the subhepatic adhesions there, which is again really diagnostic or supportive of the diagnosis. The pelvis is difficult to reach. However, if we'll reach, we'll just show you how much. Head low, please. I will just ask you. Can you reach the pelvis? Yeah. Rita, right? Yeah, head low, please. Head low. You may put in a side for Rita to push the body. Maybe negotiate and then we show the transformation. Maybe just one more to the side. Kamlesh, थोड़ा सा like बेटा अंदर निकल जा. No, not from here. So these are the challenges that you face when you get patients with adhesions. Rightfully said that we are blessed, with this place to get such difficult cases, but actually, we can't give them much except for stem cells. That's what what kind of stem cells we do them, mesenchymal. The side port also would really make a difference side out. And just like, go through the same window that go back to the original window, Rita. उसी से चले जाती, you can see. पहले वाली, this one. Go through this one.
we just are fortunate to that. Maybe. Yeah, that's a rounding, but I'm just moving. That's a bladder, so I think it's covering. Yeah, try that. Just try to support also. Go deep, yeah. Yes, she wants to put in a side port so that she can push the. So I think that side is anesthetized. The patient is anesthetized. Go on that side. So I think let's go on that side. You know, that side the patient is anesthetized. There is a nice submucous myoma with a 2.9. Yeah, I think we can switch on that side and we come back once you finish, right? Yes. Yeah. ये switch कर दीजिएगा उस side, madam की side. Okay, welcome back to OT8. Can somebody tell the history for this patient? कोई history बता दो please. चल ठीक है यार. वैसे normally तो मैं नहीं नीचे नहीं नहीं मैं तो ऊपर नहीं डालती ताकि इसमें जो कुछ पानी है उसमें. So can somebody read out the history for this patient? मेरा वो कहाँ है सक्शन का वो पैटी. अभी तो यही चाहिए. छोड़ दिया ऊपर अच्छा लगा. मेरा थोड़ा ऊंचा कर दो प्लीज टूल कोई. Okay, so we are going to go in, do a diagnostic first, because no matter what the ultrasound says, you know, I mean, I feel that you should always do a diagnostic and check out what are you heading for, because I've seen with the best ultrasonologists, when they say there's nothing in the uterus, you find a fibroid, and when they say there's a fibroid, you find nothing. So I think ये pressure कम है. कितना pressure है? अभी कितना है? हाँ ठीक. प्रेशर अभी भी कम है. ये थोड़ा फॉरवर्ड फ्लो आना चाहिए पानी का ना. हाँ तो निकलने दो एयर बबल. सी व्हाट. हेलो. ये पानी ऐसे क्यों आ रहा है? ऐसे छिटक छिटक के ऐसे. व्हाई इज नो प्रॉपर. के अंदर कुछ है क्या? ये बबल्स नहीं है बट प्रॉपर एक फॉरवर्ड जेट नहीं आ रहा ना पानी का. देयर इज सम प्रॉब्लम. प्रेशर तो कितना 110 100 कुछ था पहले. तो जैसे लास्ट हिस्टरोस्कोपी में तो बहुत अच्छा आ रहा था. क्या हुआ? What you putting it again? तो उसको 80 से बढ़ाओ ना. प्रेशर बहुत कम है. प्रेशर बढ़ाओ. वो 80 क्या हुआ उसको 100 100 110 कुछ ऐसे करो और बढ़ाओ. क्या करिए? नहीं यार ठीक है कोई बात नहीं. निकल जाएगा. तो इसको बनते रहते हैं. टर्बुलेंट फ्लो होता है ना. ठीक है. प्रेशर अभी भी नहीं है. ये सक्शन 260 कम कर दो. बट सक्शन तो मैंने दबाया ही नहीं हुआ है. बट आई डोंट नो. प्रेशर तो एडिक्वेट नहीं है. can look at the stream and you know कि ये ठीक नहीं है. Pressure नहीं दे रहा उतना. बढ़ाओ pressure, वो बढ़ाओ. Let's see whether it gets better. There is some obstruction somewhere because. Okay. Because it's all about, you know, water pressure. If you don't have adequate distension, you won't see anything inside. So, of course, we go with these gadgets and we see, you know, what we are setting at, but then you also have to learn in life that it's about your experience, you know, like when I'm looking at the stream of this water, if you have my outside view, I'm not happy. You know, this is not good enough pressure. Whatever the machine may show, if it says 110, I don't believe it. But even on increasing, it is not giving better pressure. So, कुछ तो problem है. कोई air bubble भी नहीं है. ठीक.
$49 you are on.
पूछेंगे पीछे ये वाला कैमरा दिख पा रहा है. Juhi, are you there? So which screen are you seeing for us? Okay, fine. So Rita has managed to cut the adhesions. You saw there were major adhesions. She put in an additional pot. She cut one of the major adhesions there. And can you see we've reached the uterus? Can you see the uterus there? Okay, now we'll switch off the light pot and show you the trans illumination where Kamlesh is just removing and you want to, can you see there, right? So here I am, I'm almost at the fundus there. I've anti-verted the uterus maximally. Can you see the trans illumination? I'm moving on both sides. Can you see that? There's a dark, screen there and there's a light moving right to left. So very, very close. So I've gone maximally. This is the purpose of using a dual camera system where you can use. Can you see that there? Yeah, so we are really at the front. This is the way we want to kind of help ourselves and navigate ourselves that we're not going beyond. So we'll just switch on the light and show you back to the hysteroscopic view for the last time. Can you see this? Yeah, no, the pelvis, the pelvic view. Can you see the transmission? You see, I'm just reaching the fundus. I can't, absolutely. So that's my safety check. Now put on the light, this thing. So great. We have actually gone and really put on the light and I'm back on the hysteroscopy here. So, can you see this? How much I've gone? I know it and I will not be able to give her, even if I give a cavity which looks normal, I can't give her the endometrium. So I'm going to stop short of this. The whole idea is to tell that, this show you severe adhesions, how we can cut severe adhesions with a bitoki. That's the whole purpose of this trick. So I will not go further, because if I go further, I have a very high chance of losing the wall and reaching into the pelvis as we pause the person, right? So, yeah, there's nothing. And so when you come back, I've created a so-called cavity, which is there, and this is truly a great for adhesion, absolutely obfuscated affair. Kind of getting tempted, but I should stop here because even if I kind of cut, what do I give her? I don't give her a soil which will be ready to implant an embryo, right? So, yeah, but then now for the patient, so here we are from where we started. So these are the adhesions again. I mean, I am refraining because these temptations should be kind of restricted because I just thought here. Maybe we can look in for some stem cells, but then there is not much data. Here we are sort of created for the cavity, right? So we can go back to the side mostly.
8, right? There we are. Yeah, we are done. ठीक है. So it's okay, all right. So we were actually trying to do the hysteroscopy with the 2.9 Batoki sheath, 2.9 lens with the irrigation sheath, but there was some problem in the sheath. I was just not getting the pressure. So although the pressure on the hysteromat was showing 110, but I was not getting it. But now you see, this is the kind of pressure you need forward jet. So whatever the hysteromat might say, you have to, that's troubleshooting, You can't do hysteroscopy with that kind of pressure. So now I've taken that camper trophy again because there is some problem with the sheet. तो हाँ white balance वगैरह कुछ नहीं किया हमने स्कोप बदल दिया ना दिखाओ नहीं उसमें पानी है चला जाता है ब्लू वाले से So we are now going into the vagina. Again, like I said, we actually hit the posterior fornix. And this is the os. The os is very, very obliging. It is already open, which happens in submucous myomas. I mean, I don't even have to see the cervix. Actually, I'm seeing the external os and the endocervical canal. So now, if the light lead is at 6 o'clock, then if you want to go vaginoscopic, you have to keep the internal os at 6 o'clock on the screen like this, half moon. So you can go without touching anything. You need to keep moving and keep bringing the os at 6 o'clock. I still cannot see the os though, but I'm just trying to negotiate wherever I think the potential os is. So that's the os, internal os. And now again, I have to bring it to 6 o'clock so that I go in smooth without scraping any walls. So that's now I'm inside. And you see again, like I said, you have to move your 30-degree scope. So you move your light lead. I'm moving to the right. I can see the right cornu of the patient, right ostia. And this is the other cornu. So this is, you can see a panoramic view. And this is the fibroid. It is on anterolateral, left anterolateral wall. And although it is reported grade 0, isn't it? It is grade 0 probably. I'm just trying to see. Yeah, so it is almost grade 0. The only thing, it's not a very obliging situation. I mean, posterior walls are easier than anterior and it is lateral. And the other thing which is not very easy for the operator is just inside the internal os. But anyway, hopefully we shall manage. And I'm just trying to see, that's the base. That's the base of the fibroid on the left lateral wall. And it is just inside the internal os. You see, the minute I bring the scope a little bit out, I'm into the cervical canal. So it is just inside the cervical canal. Resectoscope laga. So we will go with the resectoscope with 2.9. Okay, so that's the fibroid. That's the base. It's quite a wide base, but it is a type 0 fibroid. So let us see. So I'm going to take this out now. And while I withdraw my scope, that's the time where you can examine your cervical canal. Keep the hole in the center and look all around 360 degrees. Look at the cervical canal. Okay, so we are out and we're going to now attach the resectoscope with, it's a unipolar resectoscope with, so we will need to switch over to glycine. That is the most important. Yeah. हाँ प्लीज बैक लॉन्ग एलिस दे दो, दो लॉन्ग एलिस दे दो। अब ब्लैडर फुल हो रहा है क्या? मुझे लग रहा है इसका ब्लैडर काफी, क्योंकि बहुत देर से लेटी है ना इस बेचारी। ये क्या है? इधर देखो, ये क्या है? व्हाट इज दिस? इट्स नॉट लाइक अ नॉर्मल फोल्ड, यू नो, इट्स लाइक एज इफ यहाँ पे कुछ रेंट है। छोड़ दे, छोड़ दे, नहीं जली की जरूरत नहीं। अच्छा वो ओके। एलिस, लॉन्ग एलिस, एक एवी रिट्रैक्टर, ठीक है छोड़ दो। Yes, because we are going to use monopole cautery. If you were using bipolar, then you can use saline. You will continue to use saline. Bipolar and unipolar, the mechanism is still the same. There's no difference. It's just slightly a bit slower with bipolar, but otherwise there is no difference. The resectoscope is the same. But with unipolar, you have to use glycine, because with an ionic solution, as soon as the electricity flows, the sodium chloride is going to dissociate into sodium and chloride, and you will not see anything. So glycine, you have to be more careful, because the safe limit of fluid deficit with glycine is much lower than normal saline, because normal saline is a isotonic solution, so the body throws it out more easily, whereas glycine is hypotonic. There is problem with fluid overload more easily because it is hypotonic. It sort of sucks in more fluid. It is also, it can produce hyperammonemia. ठीक है, clear दिख रहा है सामने? हाँ हाँ मैं कर ये अंदर ही। अच्छा वो उसका, ये इसको ही रहने दीजिए बस, ठीक है। ओके, क्वार्टरी कितने पे है? मेरी आदत है उस पर जाने की। So again, if you can see my instrument outside, there are now the inflow and outflow ports are very close. So whatever is closer to you is always the inflow, and what is away from you is the suction. Is the suction on? The suction is only on when you press it, isn't it? Okay. उसको प्रेस करो कि उसको प्रेस करो, देख लो, करना पड़ेगा। चला गया, ठीक, निकाल। So I did not have to dilate, just hold it steady. सीधी खड़ी रख, don't break your back. So we are now going in, we are into the cervical canal. Top light off please. हाँ, कॉटरी कितने पे है? 30. कटिंग कॉटरी 80 पे कर दो, प्योर कट, and we might need to increase it to 100. तो सक्शन इसमें ऑन रहेगा नहीं, I know, but you'll have to keep. So no, the point is I'm cutting also. I can only use one pedal at a time. Then okay, then give this. Yeah, but actually I prefer something which there's a continuous suction rather than pressing it, you know, especially for operative. Then नहीं ठीक है, let her do it. No, I'm just, ये थोड़ा सा आगे प्लीज पुश कर देना पैटर्न को। हाँ ठीक है, कॉटरी कितने पे हो गई अब? हाँ, I don't use coagulation. Okay, so we are going in, and like I said, this is left anterior lateral wall. So it is, yeah, because it's just inside the os. That is the bigger problem. Like the minute I slip out a little bit, I'm just going to, it is vascular, so I'm just going to give little the base, just trying to reduce the flow if I can.
यहाँ पे ले लेंगे, मेरे पास जैसे आएगा ना तो कर दूंगा।
इसका इतना अच्छा ये है, इसका सबका क्या है?
मैकबुक प्रो में बीच में ब्रेक है कुछ हल्का हल्का चेक कर सकते हैं ना एक बार
Please don't be tempted to cut the pedicle and then have the fibroid floating. And sometimes then you spend hours retrieving it. It doesn't come out. Neither can you cut it because there's no way you can keep hold of the fibroid to cut. So don't get tempted to cut the fibroid from the base and then have it. There is slight intramural component, very little here. It's actually the base. I'm just trying to touch the base. So the vascularity of the fibroid now we know comes from all around. Of course, if there is a base, if it is potentiated, then it is mainly coming from the base, obviously. Otherwise, fibroids, initially we used to think that there is a pedicle, but there actually, the vascularity comes all around. Okay, I think we start because we can't see it behind anyway. तो सक्शन ऑन रखे हो ना, सक्शन को ऑन ही रखना, नहीं तो फिर डेफिसिट हो जाता है वहाँ. बढ़ा दीजिए कॉर्टी 100 पे कर दीजिए.
शो कर रहा है
कटी कॉर्टी चाहिए मुझे. प्रेशर बहुत ज्यादा है, क्या प्रेशर थोड़ा घटा सकते हैं? नहीं तो डेफिसिट ज्यादा होता है. कितना प्रेशर है? 100 कर दो, जरूरत नहीं है 110 की. What is the patient's blood pressure? कितना? 90/50 और कम कर दो, 80 कर दो उसको प्रेशर को. So the idea is to be able to see, and we can see more than adequate. Why have so much intrauterine pressure?
राजेंद्र आपका नाम है राजेंद्र ना
If you have a fibroid 3 centimeters,
राजेंद्र
you can do it easily in one go. But if you give one shot of leupride, it makes the vascularity less. It makes the endometrium thinner, and that way it reduces your operative time, reduces the fluid deficit.
वो तो कंप्यूटर फैसिलिटी वाले देंगे
3 centimeters, and certainly I would give something
जो यहाँ के है ना वो
Danazol a lot.
वही
Now
कर
we're
सकते हैं
giving more leupride, but actually Danazol is also very good. Give it for
मैं राजेंद्र नाम पे हूँ कौन
600 to 800 milligrams a day for 4 weeks.
रविंद्र तो नहीं बोल रहे
रविंद्र कौन है
रविंद्र मेरे बॉस है
वो कहाँ है
वो आए नहीं
हमारा सक्शन पे कंटिन्यूअस पैर है. हाँ, तो कंटिन्यूअस रखना. That way you don't have deficit. आप 15 लीटर भी यूज करते हो ना ग्लाइसिन, अगर आपका सक्शन ऑन रहे तो आपका वो डेफिसिट नहीं होगा. I prefer systems where the suction is on automatically rather than you have to do it. क्या हुआ? इसमें गिर रहा है, we should be able to suck it out later. That's why you should have a drape which is non-absorbing. If you put cloth drapes, ठीक है, so specimen बाद में collect हो जाएगा, don't worry. It's still not that good actually. हाँ, कितना है? तो 100 करो ना. बस 25 तो 100 करो, तो ज्यादा बढ़ा दी, 110 कर दिया. इतना भी मत करो.
कौन है वो देखिए जरा जो चेक जहाँ पे आप बैठे थे
बस that's it. Okay. All right.
ये वो जाके देखिए
Go behind the fibroid and then come into your sheath. so that you can see the loop when you're coming in. कुछ कोई बताएगा कितना गया और कितना आया? Input and output, please. Output. You need to check it every 5 to 10 minutes. 800. अच्छा बाकी बॉट इसने एक्चुअली नहीं फ्लोर नहीं, इसने bucket. It's in the bucket, but why is it in the bucket? You know? हाँ, actually वो थोड़ा सा vehicle canal में है ना. That's not a good way because then you don't know. अगर पूरा का पूरा उसमें आए ना section में, तो आपको पता रहता है कि हाँ इतना आपका आ रहा है. इसमें कोई सक्शन डाल के देख सकता है कितना आ गया बकेट में, so that I have an idea कि मेरा डेफिसिट क्या है. एक नॉर्मल सक्शन लेके बकेट में डाल लो. या तो सक्शन मशीन से लगा लो ना, आसान होगा उसको पलटने में. सारा बकेट में इतना भरा हुआ है ना. एक मिनट, मैं ये इरिगेशन है 1 मिनट बंद कर रही हूँ जस्ट टू गेट माई बबल्स आउट. See, when you get lot of bubbles, that is the trick. You can bleeding तो होगी बट कोई बात नहीं. सक्शन दबाओ. Well, deficit it's 500 ml only. You should be alarmed because you should ideally not have a deficit of a liter. Although you may exceed little bit if you think suction on that. हाँ, that थोड़ा suction बढ़ाओ तो please. But if you think you're just going to finish in a few minutes, then you may still go up to 1.5 liters. But safe is 1 liter only actually. It's diagnostic में तो कुछ खास बताया. लाइन यूज किया था, लाइसेंस से किया था, डायग्नोस्टिक भी. अच्छा ओके, इट्स ओके. दिस ये इतने बबल्स इसलिए आ रहे हैं बिकॉज सिस्टम में टर्बुलेंस है. So ideally, suction irrigation, I prefer if it is one machine or if it is like continuous happening, then it's not turbulence नहीं होता. As long as I can see, I would not want to remove my scope. When I stop seeing, then obviously I'll have to take it out and remove it. And before finally finishing, of course, I will just take it out and check कि क्या बच गया, how much is left. Now this part is little bit difficult because the full lateral wall पे है, so to keep align the if you can see my outside view, then my scope is getting absolutely पीछे लग रहा है, so that I am aligning myself to the wall because the wall पे lateral wall पे है. मुझे कोई सक्शन बताए प्लीज कितना है. इसमें भी ज्यादा बाहर बह रहा है because I'm just at the internal loss. So lot of fluid is actually going out, and that's why also there is more turbulence. If you're all inside the uterus, then you don't get so much turbulence. I will stop and just check out what is happening. Suction on करना, irrigation बंद कर रही हूँ. Bubbles will get sucked up. Once they are gone, then I will put on my irrigation. So you can, but इसमें बहुत turbulence है because ये इतना fast है. वापस भर जाते हैं। Anyway, we are almost coming to an end. But it is not a good view. It's so much. Really. We take out the scope once, clean it, and then put it again. So this part is just inside here. ये cervical canal है to my right, and this is the fibroid. So we are so close to the cervical canal. हाँ, वही मैं करने वाली, बिल्कुल करने वाली थी, वही करने वाली थी. Exactly when you said, I was thinking now I go to the opposite side. We normally don't teach to go inwards, but then when you have control, then you can cut it the other way. Otherwise, ideally you should be coming only towards the scope so that you are safe. इस सेक्शन में कितना है? तब तक फ्लूइड भी तो और चला गया. एक बार मैं निकाल के इसको क्लीन कर रही हूँ. एंड आप लोग जरा सेक्शन वो भी डेफिसिट भी देख लो, सो दैट आई हैव एन आइडिया. ओके, मुझे ना वो दोगे आप, क्या बोलते हैं, क्यूरेट नहीं, पॉलीपेक्टमी नहीं, वो यार ओवम फॉर्सन. लाइट देना पीछे की. अच्छा कोई बात नहीं, कुछ भी दे दो, छोटा छोटा वो दे दो, छोटा स्पॉन्ज होल्डर अगर छोटा है तो. और तब तक सारा पानी आप सक करके मुझे बताएं कि कितना है. ये पानी ना इसमें सक नहीं हो रहा, गॉज पीस में अटक गया. आइडियली दीज गॉज पीसेस शुड बी ऑल रिमूव so that you can suck the water and get a clear, because वो ना gauze pieces भी फिर पानी वो उसमें भर जाता है ना. कुछ भी दे दो, नहीं तो क्यूरेट ही दे दो, कुछ नहीं. और मुझे भी एग्जैक्ट बताना कितना गया और कितना आया. ये बहुत बड़ा, ये भी जाए. और ये बॉटल में से निकालना पड़ेगा सब बाद में टिश्यू. ये कैसा है, ये टेढ़ा क्यों है? तो निकलेगा नहीं. चलो कुछ और नहीं है, ये तो तुम्हारा टेढ़ा हो रखा है यार, ये बिल्कुल टेढ़ा हो रहा है, ये उसमें टच ही नहीं हो रहा. ये देख, छोटा एक स्पॉन्ज होल्डर तो कुछ है नहीं. तो दूसरा, ये तो क्यूरेट टेढ़ी हो रखी है, दूसरी साइड तो जाएगी नहीं, जाएगी. हाँ जाए, ओके. हाँ हाँ, वो भी चला जाएगा. एक्चुअली काफी टाइम. बुगाटी का सबसे बड़ा एडवांटेज यही है कि यू डोंट हैव टू डू दिस, but then you can't do it for these such big fibroids, because then if there is bleeding, then Bugatti has no method to do any sealing of hemostasis. मैं वही दे रही हूँ, बकेट में से वो सब करता है ना, करने दो. बड़ी मुश्किल से निकालने के भरे पड़े हैं. क्या स्मेल आ रही है? पॉटरी की आ रही है. कुछ और तो नहीं भैया? इज देयर एनीथिंग? Uterus is pretty big actually. You see, this is a UCL. खासा बड़ा है. चलो लेट्स सी. सो सक्शन मुझे बताइए प्लीज कितना है इनपुट आउटपुट. ये बॉट अभी भी सक नहीं हुआ पूरा. इसको एक बार सक कर लो फटाफट, इसमें डाल के प्लीज. कितना गया ग्लाइसिन? गया 5-10 मिनट गया ग्लाइसिन. कितना गया? और ये कितना आया आपके पास? नहीं फिर भी 4 लीटर्स इसमें कितना है ये, इसको सक्शन को प्लीज डालो। इसको अंदर डालो ना, उसको सक्शन ट्यूबिंग को जो वो अंदर सक करे। उसको निचोड़ देना गॉस पीस को। हाँ ठीक। ये ना लेकिन सब जो है अब ये अनस्टेराइल है, इसको मत छुओ। तो निकाल लो ना गॉस पीस को फिर। अच्छा हो गया खाली, खाली हो गया कि नहीं? कितना आ गया? ठीक है, बाल्टी से भी कर दो, खाली हो गई तो। हाँ जी, अब कितना हो गया टोटल आउटपुट? और सारा मिला के आपकी सक्शन बॉटल में भी ये भी सब कुछ, then we have to finish it off quickly now. Although this, I don't think this is a very accurate measurement, but still we can't just take it lightly. हाँ, इतना होना चाहिए नहीं वैसे, अगर सक्शन ठीक से ऑन। सक्शन थोड़ा सा बढ़ा दे क्या? सक्शन थोड़ा सा बढ़ा दे। कितना है? बहुत पानी, पानी कम करो प्लीज, फ्लो कम करो पानी का। पानी का फ्लो कम करो, पानी नीचे का फ्लो कम करो। फ्लो बहुत ज्यादा पानी, इसलिए इतना हो रहा है। इसको इसको फ्लो को 400 जिसको पता है वो करो यार, मैं खाती खाती। ठीक yeah, yeah, I just wanted, the problem whenever you remove the scope, then it takes time to get the vision. हाँ ठीक है, लगाओ, we are almost done. क्या चीज? हाँ ठीक। I know this is not nice, it's a nice नहीं नहीं, मुझे तो वो बेटर लगता है जिसमें कंटिन्यू रहता है ना रात में। ये मुझे दबाने वाला फंडा नहीं समझ में आया, इसमें एक तो बहुत ज्यादा वो है। इतना let's just see. एक बार मैं इसको बंद करूंगी, ये तो कुछ नहीं, ये सब कुछ कर। है ना, आप इसको एक बार दिखाने के लिए आई एम जस्ट गोइंग टू स्टॉप माय इरिगेशन सो दैट ये निकल जाए एक बार, ताकि अच्छे से दिख जाए। बहुत ज्यादा टेम्परेचर, नॉट नॉट गुड। पे एक बार बंद करके और इरिटेशन और इसको suck out कर the bubbles so that you can once see the cavity before you leave. The cavity is also pretty large actually. It's about 4 inches. नहीं, बस पानी से नहीं आ रहा, पानी से नहीं आ रहा, पानी नहीं आ रहा। बॉटल खत्म हो गई क्या? अच्छा, मुझे कुछ दिख नहीं रहा। नहीं हो गया, लेकिन अच्छे से एक बार दिखे तो सही, विजन तो आए से कि हाँ हो गया, हो तो गया। नहीं नहीं, प्रिंट की जरूरत नहीं है, विजुअल देखो ना, दैट्स द वॉल। वो तो कोई बात नहीं, वो तो लटकते हैं, बट सी दिस इज द बेस, सो इट इज ऑल डन, राइट। ये जरा सा ये टिश्यू है हल्का, now we are parallel to this floor, right? बेस भी काफी बड़ा था एक्चुअली, तो काफी वाइड स्प्रेड। देखो यू कैन नाउ सी द मायोमेट्रियम, द पिंक पीछे दिख रहा है। That's how you can differentiate between the myoma. This yellow is the myoma, and if you see this is all pink, this is all the myometrium. So we are absolutely sure that there's nothing left there. That is how you differentiate. Even when you have a type 1 myoma, that is when you know that you have actually reached the base. You can actually see those pink fibers. Now you see this. नहीं होगा, ठीक है, that's okay. We are all right. See again, this is easily the base. अभी भी थोड़ा सा fibroid है, और तो ये वैसे अपने आप ही एक्सट्रूड हो जाते हैं, और because they have no blood supply, it will actually. Now you see if there's a bleeder, you just touch it. I'm using cutting cautery. Just touch the bleeder. देखिए बंद हो गया ना। लोगों को वहम रहता है कि कटिंग कॉटरी से आप कॉटराइज नहीं कर सकते, बट इट इज नॉट द कटिंग और कोएगुलेटिंग करंट, इट इज द करंट व्हिच कॉटराइजेस। ठीक है, ओके, वी आर आउट, वी हैव डन। So if there is a bleeder, you just touch the loop. Even with cutting current, it will coagulate. Now निकालते हैं इसके, और कुछ बाकी तो सब ये निकालने पड़ेंगे सक्शन में से। क्या चीज? फुट पेडल से पैर निकाल लगाओ बॉस प्लीज। देखो कितनी बड़ी है, माय गॉड, 4 इंच से भी बड़ी है यूट्रस। इसमें भी तनिका अच्छा भरा होगा, लेकिन निकलेगा नहीं, ये आपने बाहर रह गया। ठीक है, इसमें से आपको सिस्टर लेना पड़ेगा, टिश्यू ना कलेक्ट करना पड़ेगा बकेट में। ले लिया? हाँ तो बस ठीक है, ठीक है, हाँ ठीक है, और ले सकते हैं थोड़ा। थैंक यू डियर। ये मेरे को एक वो देना फॉरसेप्स, ये बड़े बड़े पीस के होते हैं, एक वो देना फॉरसेप्स है। नहीं फॉरसेप्स देखो, फ्रंट टूथ एक, जस्ट टू बी ऑन द सेफर साइड, कैन यू प्लीज सेंड वन इलेक्ट्रोलाइट। ये भी पानी देना, जरा इसको भी सक कर ले तो फाइनल डेफिसिट लिख देंगे। यहाँ पे थोड़ी सी ये इसको भी थोड़ा सक कर लो। हाँ ले लो वापस। Any questions? Or have we moved the audio the other side or still with me? Okay. Anything? Any queries? Yeah. Okay. All right, I will just switch over the audio. The what you want the RAM of? Hey, we've got. Yeah, Juhi, I'm here. We are in 49. Maintain distance. Yeah. Yes. Yeah. Uh, yes. Yes. See, I'll tell you. I would say that when you do a hysteroscopic surgery, how you graduate in a surgery. So you do diagnostics, maybe do 50, 100 diagnostics to get that time. And that's what I think is kind of, you kind of sign off a person for operative. So, maybe 50 diagnostics are good enough. You graduate to do septums, which are the easiest ones because they're visibly large and you can cut them with toki and whatever. Then you go to cannulate and then myomas. And then the ultimate in surgery where you feel you've reached excellence is adhesions as in grade 4 like this. So certainly, it requires just not just skill, but of course a little bit of know-how about navigating with your this thing. The first question is pressures here are the same. Again, I would know that we have an endomatic select, but suppose we don't have an endomatic select, which is a costly affair, even on a Hamau hysteroscope. As Dr. Renu Mishra was telling, ma'am was telling, the pressure ideology, the fundas, not to go, never to go before 100, 110. So you that's the way because I know that I would be doing it. I'm doing it because it's doing under Petoki knife under saline, but saline doesn't give me leverage that I can have. Obviously, the trade-off between use of glycine versus saline, you have a little more safety margin. Anything upper limit with glycine would be 1,800 to 1,000. Here it be 1,200 to 1,500, but that doesn't give me leverage that with saline I can go. So, you have to really gauge how much of fluid you're giving, what pressure you're giving. So I would certainly not go beyond 100 to 110 for my thing. The reason why I'm saying is that when you do a adhesiolysis, of course you are going slow, but time is taken. Therefore, there will be a time when you will be, you know, you may spend extra time. So remember, the amount of fluid deficit is also proportional to the time that's spent during surgery. So if you're quick in a surgery like the one we did, we hardly took those. But if you're doing a long surgery, the deficit is bound to be more. So keeping that in mind, so that's what I would say. Not a pressure going beyond that limit. B, ultrasound guidance, yes, you can do it. That is another way of a safety check, but I have effectively not been able to do an ultrasound guided hysteroscopic adhesiolysis ever. So in this case, also just for the academia or for the research or whatever, sorry, the purpose of showing you guys, we put in the port. Otherwise, we would have not put because we knew that she had findings and knew that she's a grade 4. But yes, ultrasound may be an alternative, and there are some kind of, ways where people describe, but ultimately it's your skill where you know where you to stop and where to go. Getting an ultrasound for AIMS to the OT block or to the OT would be very difficult and challenging, but it's set up. And how easy it is for you to get an ultrasound to help you, I don't know. I don't think it is all that easy to put in a probe on the the abdomen and see. I have no experience, so I would not be able to say that use under ultrasound guidance. I hope the answers, both the questions have been answered. Yes, this patient induced. We are going to do a tubal cannulation, and I believe Professor Gannon has also joined. He's there, but we will probably be able to show you one case here. We'll be easily showing you. Yeah. So we'll be doing a certainly this requires a laparoscopic guidance. You put in a port inside to really know whether this patient is suited. Many times you think you look for Gayatri. Juhi, where do you want Gayatri to come from? Gayatri is in this side of. She said okay. So Juhi, I want to tell the people who have viewed it, the patient has been induced. The first check is to put in a port in the pelvis, basically to really assess she's fit, because we see there are corneal blocks. We are excited, we put in, but if suppose she has terminal hydrosalpinge disease, she's got adhesions in the pelvis, you have to really see what is the extent, and only then, because suppose she has bad, adhesions, terminal hydrosalpinge, is it making any sense?
Of course, we'll view the pelvis and then we'll start doing the cannulation from below. So this is case of cornal blocks. Presumably, the cornal blocks are the ones where you are you may have a chance of 45 to 50% false positivity because it is done without anesthesia. And when you put in a port and you put in the dye, there is no cornal block. But however, what we'll do is we won't put in the dye. If things are clean, we'll still do cannulation to show you. Because I think when we put in patients of cornal block, more than half of those cases actually are open tubes. But we will not do that because if we do that, then we will not be able to show you that this is a case of cannulation, right? So we will go ahead. Okay. Yeah, please show the PPT of the patient's history. मैं ऊपर डालूं? I'll put in the port ऊपर. Rita, तू नीचे बैठेगी ऊपर कहाँ जाने के? Where do you want to go?
9 years old.
मैं ऊपर आ रही हूँ.
With secondary infertility since 10 years. She's cohabiting with the husband and there is no coital difficulty. The last menstrual period LFP was 26/21. She's having a regular cycle with normal flow. Obstetric history, she had one spontaneous abortion in 2010 and 3 months POG. No DNC was done for this patient. Her past history is otherwise normal. She didn't have any chronic illness and she didn't receive any treatment or OBS. Her examination is normal. Investigations, her HSG has, this is a picture of the HSG which is showing bilateral corneal block. So she stands for diagnostic laparohysteroscopy and chromoperturbation with triple cannulation. Her HSG is, surface image analysis is normal.
वो कुक्स वाला मिल गया ना नया. हाँ रेनू नोबिस कैनुला सेट खोल लिया ना नया. Live. Come on. Take it from where is this thing? Cannula set ले लो. So we're going to use a Cook's cannula set. It's a novice cannula set. No, okay. Can you hear us? You know, the beauty of cannulation is that this is a patent by Cook. It is a brilliant cannulation system. It has got a metal obturator, and following the metal obturator, there is a sheath, you know, which we put. Now this metal obturator actually helps you go in and reach. And as Rita is going to sit on the hysteroscopy side, I'm on the laparoscopy side. And this cannula has a very beautiful peculiarity, which we'll show you once you're done. We'll show you that cannula system. So it's called a ostia finding tendency. So this, you know, cannula, the outer sheath, once you withdraw the obturator, the metal obturator, it actually itself snugs itself into the ostia. That's the beauty of the system. And once you snugged in with this outer sheets, you push in a guide wire. Now the guide wire is the catch. So think of it, you know, I always tell the analogy of this is, you know, I don't know how many of you have used or seen some kind of a person from the sanitation works come and declog your kitchen, you know, pipes. So when there is, if you've seen, you know, I don't know how observant you are. So when there is some kind of a blockage in your kitchen tubings, there is somebody who comes in, uses a kind of a instrument which pushes the obstruction. So this guide wire which goes has got, it's a very, very sharp guide wire, right? So once the ostia have been snugged by these outer cannula, then you push in the guide wire under the laparoscopic vision, which we'll show you, and you just kind of put that wire and just guide the wire until you feel the resistance, withdraw and then push the outer. So, you know, your outer is the safety check because it's such a thin wire that it can perforate the tubes. So that's the technique which we'll show you out once we've done the procedure. And think that this guide wire is the one which is bypassing the obstruction which is there. So you are under cover of that outer softer sheet through which you keep kind of pushing those guide wires which are really sharp end, which is the sharp end. And then there is through this novice cannula, you have kind of a dual channel. Through one channel, you push in this guide wire, and through other channel, you push in the dye. So once you are sure that you have kind of bypassed the obstruction, you push in the methylene blue, and then you will be able to kind of see the dye spilling through the fimbrial lens. ये table नीचे कर दीजिए lowest, और डालेंगे. Lowest मतलब lowest. पहले ऊपर कर लेते हैं. इसी से नहीं, इससे मत कर, इसी से कर. Why did I disturb? I can do it here. Oh no, what I know. सुनो, मेरे को देखने के लिए मुश्किल होगा. हाँ, ठीक है. So we are just going to swap this thing cameras here. We will be putting in the VDs and creating pneumo, and then enter the pelvis first. See the feasibility of. Can you focus on the abdomen? Yeah. So. Ma'am, ये वाला है ना, because मुझे. That is the issue. So it'll be quick actually. So we on कर देना है जी. Then I'm using a port. मैं शॉप करना गैस. Better. Can you, because he's actually logged in. You can say we just show one case if we can. 15 minutes, maybe, because we'll at least 15 minutes, because we still have 10 Pinterest. So maybe 50 to 125 we should be there. Give me a 10 and 4. Thanks. We'll show you. Gas on कर देना. अभी स्क्रीन ऑन है. Gas on. Easily. This got a lot of adhesions. Actually, I had challenges filtering it. Yeah, yeah. It may not be suited for us. That's a potential not in filling much. That is because I had difficulty in entering. Yeah. I'm trying to go through. So we've entered the pelvis. Can you see the screen, Juhi? You know what? This was a little bit of challenge when I was entering. So there's a bit of port side bleeding I want to show you. So don't get alarmed. There's nothing abnormal. I knew that there was difficulty when I was putting the VDs, a challenge when I was putting in, but you can see there are adhesions here, right? So I think we'll show you the hysteroscopic finding, which she doesn't merit a cannulation because if there are so many adhesions here, I'm trying to kind of navigate myself where I can find a window to enter the pelvis. We could enter through. So you know the idea. There I am. I've just so head low kar dijiye please. Yeah, head low. So this looks good here. So head low please, and we'll put the side pots and then we'll see what is the cause of these so-called adhesions are there, right? There are some adhesions in the POD, Pouch Douglas, but they are just flimsy, can be done away. We're seeing the tube and also the other end. You can see both the tubes are there. So we'll put in a side port, see the feasibility. But if it's not, we will really not push in because it's. We'll still show you the hysteroscopic findings. All you know, there are some findings there as well. Top light off, Kardana, please. I will just put in a side port. So it is important to actually view and so always put in a pelvis, a scope in the pelvis and then put in. Which side port is. So
लाइव चल रहा है
TV चलेगा ये? Sorry? Could be, yeah, could be, because, and again, could be PID as well, we don't know, but then it is a level top light down, but it's the extent of adhesions are based on the extent of the infection. So it doesn't look like endometriosis at all because it's a clean pelvis. Such kind of adhesions don't suggest endometriosis because there should be some peritoneal lesions, should be some burnt out lesions. The ovaries are absolutely healthy. There's a direct. We'll just not do a diagnostic, we'll go directly with the 1.9 operative. We have got the Nobis cannula here. We will actually negotiate first on the right side, though there is a bit of, because here there's no point in, I mean, yes, I know, I understand you should do a diagnostic, but because of paucity of time, because we have to actually get connected with Ireland, because Professor Gannon is going to give a talk and he's already logged in, I believe. So we got another port, we got another screen on the other side where we will show you later, but as of now we are going on the hysteroscopic side. Right. White balance कराना दिल्ली. हाँ, सर्कल बड़ा है. एक बेड की देखना, बेड पर. You want the table to be there? सीधा कर दो table को because channel बग है. So we just entering in. अभी but हाँ टाइम ठीक है. ओके, ये हमारे लिए फायदा है. So Rita is entering and she's going in. She's showing you. Rita, can you take this recording from your my side to your side as possible? Okay, so Rita is showing the left ostia there. Mike मैम की तरफ ले लो. मैम मेरे को काफी मैम को दे दो. Okay, so you know the Mike मैम को दे दो. Yeah, this is a hysteroscopic finding. So I'm able to see the left cornua, or this left ostia, so which looks open. So as we decided, ma'am showed you the laparoscopic findings. So we have decided to do on the right side first. So but here we can see the cornua is occluded. This is not open. So which side we should do? So the ostia which we are able to see, I think we'll do the cannulation on this side. So this cannulation set has both this inner system and outer system, as ma'am told you, and both the system had one guide wire and one cannula. So I'll take the outer system along with its guide wire, and I'll try to negotiate this side of ostia. Okay, ma'am. There are some periosteal lesions. Now this is the outer system which has come. So this is this outer sheath, and this is a guide wire, inner metallic guide wire. So our aim is to basically first negotiate the ostium. Do we have to move this camera? Yeah, we are doing the first the left cornua, and once I have negotiated the cornua, so now slowly I'm taking out the metallic this and negotiating with the this thing. So now we can do the dye test, and simultaneously we can see from above. If it is open, it's fine. Otherwise, we will have to use the inner cannulation system also, which will cannulate the whole tube. So dye. So we can have both the views, laparoscopic and hysteroscopic view, because if possible, this procedure has to be done under laparoscopic guidance. Dye डालो, यहाँ से डालो, दिखता है, दिखता ग्लव पहन के आ जा, कुछ बताइए, नहीं 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 नहीं, तुम पकड़ो मैं डालती हूँ, ठीक है, that's is it cool with that? If dye doesn't come with this, then we'll have to cannulate the tube, which means the block is beyond the cornua. ये नहीं कि रुको रुको, वेट 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 वेट, ये वही ना सेगमेंट के बियॉन्ड से नहीं जा रही है. हाँ. Hmm. Hmm. Should we try the system now? थोड़ा सा system ना, इसका फिर मेरा विजिट चला जाता है. नहीं. अब देखना, अब देखना. Then we'll try the next one. पूरा कैनुलेट करना है, तो दूसरी साइड पर ले देते हैं. नीचे. Outer guide wire. So here actually we have to really see what is the exact location of ostium, because it is not looking, it's completely obliterated. chronic and strawberry type जो picture जो है ना मैम there are micro polyps and there are strawberry picture like the multiple pinpoint hemorrhagic points. So there is some evidence of chronic endometritis also. So these areas. So, so this, and she didn't have any endometriosis or anything other cause of this corneal block. So maybe she had component of PID and endometritis. See here also. See this is also micropolyps. So which are classified as the features of chronic endometritis. And there is one point, her ostia is open, so there are no adhecrans. So the area, periosteal area is also fibrous. So all these are features that she may not be a good candidate for cannulation. It is a fibrous periosteal area. Yes, so now we are going to the other side. So this is the right side of the corner which is completely blocked. Here actually we have to assume what is the likely site of ostia and then start cannulating. So can you see this? No. We're trying to see where is the exact location of ostia which guide wire this is helping us. And actually it's very important to see because we may perforate the anterior or posterior area also. So then the laparoscopic helps us that whether we are going in correct plane or not. Then no place. This is again blocked. Yes, we'll show you the PF. मेरे को लग रहा है कैमरा बुक कैमरा कैमरा बुक मेरे को गाइड देना अब इनर वाला गाइड वायर भी देना है Then dye is going freely. इसमें दिखाती हूँ पुश करना था, पुश तुम मेरा नहीं पुश करो, इसको तुम पुश कर, जा रही है गाइस, गाइस जा रही है, नहीं नहीं रुको रुको, ना 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 सीरियसली जा रही है, एक्स्ट्रा वेजिटेबल, आई थिंक सोच रहे हैं हाँ, इंद्रिया देखो, एक बार इनर डाल दो फिर साथ में, yes, okay, yes, we'll try, yes, we'll do that one, okay, okay, yes, एक minute. I'll push in the inner valve. We may not be successful because this ostia was completely blocked and fibrous. Still, I'll try once to push the inner system. Fibrous लग रहा है ये पकड़ो ऐसे, कैमरा ये लाइट पर, इसी तरह का ट्राई करेंगे जब for inner system we have to fix the this outer sheath, and now I'll take the inner system. Now, now, yes, ma'am. तो थोड़ा anterior भी करते हैं, ऐसे रखना तरीका, inner system दे दो. The inner system has again both the system guide wire and the sheath. So along with the guide wire, I'll try to cannulate the tube, and then on laparoscopy side, we will see whether we are going in right plane or not. Because this case is really the challenging one where we are not able to see where is the opening. No, outer inner system. Inner system, please. Just lock लगाना अच्छे से. लाइट नहीं, इसका वो चाहिए आउट शीट का, साथ में कर. बस इससे करके करो. बस आगे थोड़ा और पीछे और पीछे और पीछे. बस अब लॉक कर दो. Yes, ma'am. इसे पकड़ के रखना. Yes, ma'am. So I'm putting the inner system. So once I go till the cornea, then I'll take help from the laparoscopy side whether I'm negotiating in the proper plane or not. Because in these cases, then we may go in the wrong plane and we can perforate the tube. ठीक है.
side is totally blocked there. No. This seems to be actually fibrous tube, so I'm not able to negotiate that this side also. See, we can see this with so many periosteal adhesions and fibrotic areas. And this opening which we have made with the outer system, so it is not correctly communicating with the tube, and so cannulation will not help in this patient. Yes, the area looks okay, but एक बार तब तक we'll try on the other side. By that time they can see the polyp there. So we are trying once on left side. So then we'll show you if we are able to do this on left side. Button. फिर हम बुगाटी लगा रहे हैं इधर. Hello, are you with me? Yes, ma'am. Okay, so I'm just showing you this polyp, and then I'm going to take out my scope, and hopefully we can show you a polypectomy with the Bugatti shaver, which you can use for small myomas and polyps. Okay, so just want you to see this, and I'm coming out. Right, that's the ostia on the left, and that is on the right, and this is the anterior wall polyp. Okay, ठीक है, अब वहाँ पे कर सकते हो वापस, लेकिन हमें वो चाहिए, आप बुगाटी का सामान चाहिए. ये इसको संभालना सब. हाँ, इसको ऐसे हिलाना मत कोई भी ना. इनर सिस्टम देना. रेनू, रेनू है यहाँ पे. कैन यू टेक ऑफ माय ऑडियो? हाँ,
Just 1 second.
तब तक देखते हैं इसको चला के. नहीं लगा, इसको हटा लो. हाँ ठीक है. नहीं, मैं कह रही थी इसकी तब तक मोटर लगा दो, हम देखें. इसको हम ऐसे रखेंगे ना ऊपर ऐसे. या वी जस्ट गेटिंग रेडी. पद्धति क्या है? व्हाट इज दिस? अच्छा ये नहीं लाइट सोर्स, ये लाइट सोर्स है। हाँ ओके, कहाँ लगाना है इसको? अब अच्छा ओके। या are you is the audio on my OT? No. Oh okay, ये दिखाइए बाहर से, मैं इनको तब तक ही दिखाती हूँ। Okay, so where is the tip of the Bugatti? Cut portion इधर है ना? Can you see this? Now you can't see this move, but this is the end. Camera closer. इसको focus करो. Can you see it? Okay. तो इसमें भी ये दोनों लगाने पड़ते हैं. So they have, like what I showed you earlier, in the first case, we have to put the same endomat, the irrigation and suction, and this is customized. You can only run the Bugatti with this. So otherwise, because we had the Hystomat earlier, now we're putting it back. Sorry? इसकी आवाज थोड़ी बढ़वा देना, मैंने ही कम करा दी. हाँ बीच में कर दो. हाँ हाँ दिखा दो, थोड़ा दूसरा ओटी में करा दो. Hello. Hello. Yeah, Juhi, actually we have again tried on the left side. So we have cannulated the tube with the inner system. So we'll show you both the hysteroscopy side and the laparoscopy, and we are able to negotiate the tube with the inner system. So the dye is coming. So we have cannulated the left tube, so which we wanted to show. Push the dye. So I pushed my inner system up to the mid segment of the tube. So maybe there was some block in the middle segment, so which got opened by the inner guide wire. So now the dye is coming. Yes. Yes. So the ostia which we were able to see initially, so that ostia we have been successful to cannulate this side. So we are pushing some saline now. Just saline. And now while we'll take out the inner system, so we can see how it is coming out through the tube. So I'll just show you after pushing some saline. So in the laparoscopy side, so I see here is I'm taking out the inner system. Yeah, like this ma'am is showing. So CIP. So here it is tough because my inner sheath is inside. So now slowly I am taking out the inner sheath. Yeah, like this. So now inner sheath is out. So now I'll take out the outer sheath, and so this tube is successfully cannulated. Yeah, thank you. Like this, we can see now the eddy currents are happening. So because it was initially totally fibrosed osseous, so now it is a patent one. And are you able to see the hysteroscopic picture, and we can see the eddy currents here? So now the tube is actually open and at least mobile, so which was initially blocked. So but unfortunately we could not do other side because here the total cornal side was totally fibrous. So this is not an ideal situation for doing cannulation. So thank you so much. Although क्या अंदर पानी नहीं आ रहा अभी? Yeah, we just ready to put in the Bugatti shaver. So suction, this is suction, this is irrigation. So again, if you want to see, oh, okay. So I'm just putting this off. This is irrigation and this is suction. The suction, the chips which are cut automatically come into this suction. हाँ ठीक है डालूं मैं? Are you all ready? निकाल लो टॉप लाइट ऑफ इसको सीधा पकड़ लो बस ऐसे पकड़ लो या कैसा दिखता है वेरी डिफरेंट Where is the boss? Yeah. Show the picture afterwards. The ultrasound shows अंदर का व्यू क्यों नहीं दिख रहा टेंशन नहीं हो रहा भाई कितना है इसका प्रेशर बढ़ाइए इरिगेशन आई थिंक इट्स 80 ओनली दिखाई नहीं दे रहा मुझे कुछ हाँ प्रेशर बढ़ा दीजिए थोड़ा सा ठीक है नहीं हाँ बढ़ा दिया उससे हाथ अटकता है मेरा नहीं दिखाई दे रहा है इसलिए बुगाटी से लाइक यू सी फ्रंट क्या डायलेट करना पड़ेगा क्या जा नहीं रहा डायलेट करना पड़ेगा नहीं जा रहा little bit thicker ये जेली नहीं चाहिए मुझे एक डायलेटर और चाहिए इससे थोड़ा मोटा चाहिए ज्यादा मोटा ये बीच का नहीं है इन दोनों के कौन सा हाँ ये चाहिए okay all right let's try again इसमें you actually see this Bugatti shaver से जो आपका जो लेंस है वो बहुत पीछे है so that is the problem so you don't have to put it too much inside otherwise you can't see okay okay इसको पकड़ोगी थोड़ा सा ऊपर ही I need to get clearer picture ठीक छोड़ तो सक्शन मुझे दबाना पड़ेगा तभी होगा ना हाँ हाँ ठीक है आई नो हाँ हाँ just to हाँ yeah just to clear it so you need to keep it on the collet yeah the blade is here no Blade has to be in a position. So it is chipping. Can you all see it? It's basically chipping the polyp, and it also gets sucked out automatically, so you don't lose vision. Maybe if it is little firmer, then it cuts better because it's very soft, the polyp. Let me just cut this. It's troubling me so much. By the way, I'm not very experienced with the Bugatti shaver. So it doesn't cut anymore. Is it because it is so, anterior wall, so it is difficult to, now that it is almost flush with the endometrium, you can't get the blade. Suction तो कर ही रही हूँ ना when I'm pressing it all down. हाँ मैं तो lower down ही use कर रही हूँ. I'm using the suction and this irrigation continuously. The problem is it is so much at the fundus that you can't sort of get that in easily because it is almost flush with the fundus. You can't get it to align. Like if it was posterior wall, then it's probably easier to align. Okay, I think that's it. Yeah, osteomycina. This is just, well, this is not the best case because anterior wall पे है बिल्कुल. So हाँ, I know. उसको align नहीं होता वो. हाँ, वो उसको हाँ because it's anterior wall बिल्कुल fundus पे है. So it doesn't take much tissue. See? Okay, I think that's it. Nothing more to be done actually. You can see, yeah. Okay. Okay, thank you very much. Thank you for all the assistants, nurses. मुझे सबके नाम नहीं पता है. आपका नाम क्या है? Sonika. Okay, so Sonika is the nurse assisting me, and we have a brilliant team of anesthetists. Dr. Devesh and Dr. Mohan. Dr. Mohan कहाँ गए? Okay, so I think we can now switch over to Dr. Gannon. 9 minutes late? 1 o'clock. मैंने 1:30 के लिए उनको बोला था we'll start at 1:30. ठीक है, अभी क्या बजा है? 1:39 हो गए ना. So how उनसे पूछो, has he logged in? Is it? नहीं नहीं, हमें कैसे दिखे? हमें स्क्रीन पे दिख सकते हैं कहीं वो बाहर ना? कहाँ? इस पे? नहीं नहीं, जो लेक्चर होगा वो थोड़ी ना दिख ये नहीं, इसको रहने तो मेरे को बोलना है अभी. Yes, yes. Yeah, I am just trying to see where I can see him, you know. I'll just check if outside, you know, where they are transmitting the OT, if we can see him there. Otherwise, I'll have to see somebody else's phone. Somebody must be having a laptop there. Is it? Somebody has a laptop there logged in? Does somebody have a laptop logged in? आप हमें वहां का दिखा सकते हैं जो जूम से लेक्चर होगा? कितनी देर लगेगी? करो करो फटाफट, बिकॉज यहाँ का ट्रांसमिशन बंद है अब. Just give us a minute. We are logging in to the Zoom link. हेलो, हाँ जूही. हाँ, उनको उनको कहना कि होल्ड करेंगे, जस्ट स्क्रीन शेयर करके रुकेंगे. लेट मी इंट्रोड्यूस हिम. ओके, बोल रही हूँ वो वहां जाएगा क्या जूम पे? नहीं नहीं, मैं जो बोलूंगी वो जाएगा. हाँ, इससे कुछ मतलब नहीं ना जो मैं कान पे लगाया. ओके ओके. So, ladies and gentlemen, thank you for waiting, and thank you, Professor Gannon, for waiting. This is our star attraction of today. It's a great privilege and honor to introduce Professor Michael Gannon. He is connecting. Can you hear me all?
Absolutely.
Am I audible?
Yeah. Yes.
Somebody has to give us, let us join in. We are waiting to connect on the Zoom. Yeah, we're connecting now. Okay, इसको full screen कर दो. अच्छा, okay. So Professor Michael Gannon, currently he is the consultant in obstetrics and gynecology, Regional Hospital, Mullingar, Ireland, and he is the clinical associate professor at Royal College of Surgeons in Ireland, and associate clinical professor, UCD School of Medicine. Earlier, he has University of Leeds. That's where I had the honor and privilege to work with him and learn hysteroscopy from him. I must say he is my teacher and mentor who taught me hysteroscopy, and that's how I'm here today operating. So thank you so much. And he is as an academician, he has a lot of research to his credit. When I was in Leeds, we were doing a mistletoe study on comparing the roller ball and the loop for TCRE. So he was lead investigator of the first randomized trial comparing endometrial resection and abdominal hysterectomy for women with menorrhagia. He's done extensive clinical and research experience of orbital ablation for menorrhagia. I still remember he was so passionate about doing the menorrhagia clinic and the TCREs. We always had at least 2 or 3 TCREs in the OT and some redos also. And he was so passionate that if you called him in the working hours and you would call Dr. Gannon, he would answer as menorrhagia. So that had become his nickname for Leeds Infirmary. That's what I remember from Leeds. He's pioneered use of topical 5-amino-phenolic acid for endometrial ablation, which I don't know much about. We've already had a lecture for him last time in the last conference on this. So there is a lot which I can talk, but I think we've kept him waiting so long. We are already late. Just in 1 o'clock.
No, thank you very much, Renu. Thank you. It's always a delight, really, to hear you again. And thank you for the very interesting title that you've given me. I want us really to just think about today. You're talking about hysteroscopy, fluid management, and various then procedures for the polyps and for the tubal cannulation. And really, if we think of the uterus as gynecologists, women think of the uterus as a place where they have baby. And if women think this, and then they come to see us with abnormal bleeding, they come to see us with subfertility, and we meet and then we decide how are we going to investigate this. And really, I wanted to maybe think about today how we were going to go about hysteroscopy, whether we should be doing these procedures awake, whether we should be doing them asleep. I mean, if you were to ask a woman, and I will always ask the woman what way she wants us to approach her investigation, and 9 times out of 10, if you say to a woman, we're planning to do a hysteroscopy and a procedure for you, she'll say, I'd like to be asleep, please. Yeah, and is this good? Is this not good? You know, the anesthesia really was only introduced just over 150 years ago, and there was an enormous change in what was possible when anesthesia was brought in. And this is the case, the first case, well, it was a dental case really in 1846 in Boston. And after that time, there was an enormous take-up of anesthesia. And by the end of the 19th century, EUA, with the emphasis here on the anesthesia, was in widespread use. And 50 years after the introduction, then D&C was becoming the daily bread of the gynecologist. This is according to a big proponent, Kelly, in 1921. Just 100 years ago, D&C was a very popular procedure for investigation of women with abnormal bleeding. And remember, I suppose historically, that this is just over 100 years ago. During the following 50 years or so, D&C was the mainstay of investigation. And gradually, after that time, we saw the introduction of hysteroscopy. And if we look here, I'm sure that this is a hysteroscope that you're familiar with. This is the Bertocci hysteroscope, 5mm continuous flow. And this is still, even though this hysteroscope is over 20 years old in design, it's still my go-to instrument. If I suppose if we move on here to no, sorry guys. No, this is I suppose the original techniques. And part of the development of the hysteroscope really was trying to get it small, trying to get it so that it was possible to carry out the investigation and the examination on an awake woman. And we're looking here at a 5mm sheath with carbon dioxide, with the speculum and the tenaculum to hold the cervix, with local anesthetic to take the pain away on the cervix. And these were all described in the 70s and the 80s, all of this development.
Can you put your slides on full screen, please?
The diameter is very important. And I think that if we look here at the diameter of the telescope, the original ones were 4 millimeter in diameter with the rod lens and give really good view. And then on the other hand, the little newer ones, less than 2 millimeter fiber optic, they're very delicate and view is not so good. So we've ended up in the middle here with the rod lens system that might be up to about 3 millimeters in diameter. The outer diameter of the telescope is what the patient feels. And over 5 millimeters, really, you're getting to the stage where you've got very good flow, but you need to have dilation of the cervix and you need to have anesthesia. So really, this is not practical for day-to-day use. With the 4 to 5, most people have ended up using these instruments, outer diameter of this is like the Petacci, with the continuous flow system to give good view and probably no dilatation, and in selected patients, probably no anesthesia. Now, moving down to the narrower scope, sometimes single flow. Nowadays on the 4 millimeter, you're going to be able to get continuous flow, but the benefit here is that there's no dilatation and that you can use this in women who are not suitable, really postmenopausal women, women with no babies. Using a we're all familiar with the vaginoscopic approach. And then this was using then the Petacci scope with continuous flow and allowing the introduction of 5 French instruments. Now, he described a 30-degree lens so that when you introduce it here, this is the view that you're getting. You're looking down here, and this is the cervical opening here. Now, you can see in the diagram here that the cervix always appears like this in women who've had babies. Rotate the scope then through 90 degrees. You can imagine if you rotate the scope around here, you're looking out to one side. But the shape of the Petacci scope then takes up this shape. This is the shape. It's not a round 5 millimeters. And so he's managed to squeeze an extra little bit of space by changing the shape of the outer scope. And this, we're looking here at, this is one of Adam Magos' studies now, where he's looking at a traditional where you're holding, basically where you're holding onto the cervix versus a no touch where you're going directly through. Now he's using in this study a 4 millimeter scope in a 5 millimeter sheath, which is single flow, which is probably a bit dated now at this stage, and versus a smaller one, 3.7 millimeter sheath.
Hello?
And he's measuring.
Your slides are not
and the effect there of the hysteroscope size. Now he's looking here, outcome, local anesthetic, in the no touch, 3 out of 30, in the traditional 7 out of 30. Basically, with the bigger ones in the no touch, 8 out of 30. So that he's looking really at 18, about 20% requiring local anesthetic, 18% requiring local anesthetic, really, which is high enough. It's and Petacci says just 4%. Renu, they're not full screen. Full screen. You're joking me. What? Yeah. Yeah, I can call you on the phone, that's all. Hang on now. So you're hearing me talk, but you can't hear the slides. Okay. I'll just end show. Okay, end show. Now let's go back again. Slideshow. I'm gone back now, back to the beginning. Here we are. No. Are we on slideshow now? No good. What you? End show. Okay, end show. Stop share. No, okay. Live and share screen. Live and share screen. This one there. Share. Now, can you see that slide there, the uterus? Okay. No. No, still not. Can you see that slide? The uterus office hysteroscopy?
Unmute. Can you hear me on the Zoom now?
Yeah.
So just see if your slide moves, then you can simply, stay in the same mode and keep going. But does the slide move? Yeah, it's moving. It's moving.
Well, oh yeah, I can just move it down manually down the side without going into the screen show.
Okay. Yeah. We'll have to then carry on like that because it's not full screen.
Okay.
Okay, you can move on to whichever slide.
Yeah.
We were hearing you all right, but we were not able to.
Oh, okay. You're hearing me. Okay.
Okay.
Yeah, we're good on this little slideshow. Yeah, okay. So there, yeah. So I was just discussing really the anesthesia for patients, and I was discussing the traditional technique, and then I wanted really to move on and talk about the size of the hysteroscopes. Now, a lot of what you were doing today was asleep patients. Do you know what I mean? And I just wanted to look at awake patients and what their need is, and I just think that the ideal outer diameter is, from our point of view, between 4 and 5 millimeters. But there's a move now to improve the optics and the telescope so that we can work with a smaller outer diameter, which is really going to make life, I suppose, easier overall, particularly for older women and for women with no babies. But it's perfectly possible to use a 5 millimeter regular hysteroscope with continuous flow and with an instrument channel, and use it with the Bertocci technique. And I was looking here at traditional versus no touch. This is Adam Magos's study, where he looked at traditional with the speculum versus no touch, and the outcome measure was need for local anesthesia. This was the main outcome measure that he was looking at in the study. He also looked at the time and the effect that the size had on it, and looking at traditional and no touch. Local anesthetic in the no touch was needed in 18% of women. And I just got to this stage where I was saying that this is a significant number of women compared to what Bertocci had said, that he was saying that only 4% of his women needed anesthesia in addition to whatever setup he had with them. So I was looking at I looked at our figures. So I just picked out there several years ago, I looked at over 300 women who had hysteroscopy, awake hysteroscopy with no anesthesia, no preparation. So the important thing really that I wanted to touch on today was that the situation for awake hysteroscopy means that the patient must be informed, must be relaxed, and must be in a good place so that she goes along with what is expected of her, and that she knows that she's not going to have a terrible time, and that she knows that it's going to be reasonable. And the vaginoscopic technique will certainly provide this, where there's no speculum, no preparation, no anesthesia. Locate the cervix, and then stay in the cervical canal. Now, I use a 12mm telescope because a 12-degree telescope. Just show you here the difference, where the view is more direct using the 12-degree lens, and it's easier in that way to navigate through the cervix. And it's particularly easier, I suppose, looking at the tubes, where I was doing a lot of work with sterilization, and I needed to be able to directly look at the tube. With the 30-degree, you're looking a little bit off, and sometimes it's difficult to locate something or to instrument something directly in front of you. Now, on our patients, obviously, most of the premenopausal were normal. 10% had some polyp or fibroid. And in the postmenopausals, 22% polyp or fibroids and 2% cancers. And then this is just an outline of the additional procedures with no anesthesia and 15%. So in the end, just 5% of them needed to go on to have a general anesthetic, I suppose, which, from a point of view of providing an outpatient service, ticks the box really with that. Now, failed hysteroscopy because of cervical stenosis in postmenopausal women and discomfort in premenopausal women only occurred in 4%. And so no-touch hysteroscopy completed without anesthesia in our series was 96%. This is more like what Bertocci was finding, and much better than they were achieving in the London study. So I don't know why that was. Now I will need to let's just see if this one works. Is that one working for you? Renu, can you see that one?
No, not working.
No video.
No video.
Can you see the slide?
I can see the slide with one big black box, but no video.
No video. La, la, la. Okay. Can you see this slide?
The slide hasn't moved. It's the same slide.
Have you seen? Now, are you looking now at the slide? Is there a slide of an MRI picture?
There is a slide which says age 47, and on top there's a big black box and no video.
Okay. Sorry.
Maybe you can just minimize
Go
this.
back. I'll go back to the way I was. Yeah.
You can play the video separately from your desktop.
Let's see. Well, the video is just now. The video, I just wanted to show you really on the video. I just wanted to show the technique for introducing a hysteroscope in an awake patient. And
so just minimize the slides and play the video from your desktop.
Yeah. But we've got it's in the talk, but I can show you from here. Can you see this MRI picture? I have an MRI picture here of what's on screen at the moment?
Yeah, I can see the MRI picture.
Oh yeah. So there's the uterus. And there's the direction of the vagina.
Right.
So we can just see there's the direction of the vagina. So if we introduce the hysteroscope here in an awake patient, you can see obviously that it's not going to go through the cervix straight away without adjustment. So if then the hysteroscope is brought up so that it's looking at the posterior fornix. So if we look directly at the posterior fornix, and then we'll find the cervix, and then move it so that the cervix is in front, and then move on so that we can see that the essential movement here of the hysteroscope is that we're introducing it this way and we're ending up this way, so that we really have to move the telescope quite an amount to be able to get into the cervix and the uterine cavity comfortably in an awake patient. I mean, in somebody who is asleep, obviously we can just get a hold of the cervix and stretch it out so that it's much easier just to introduce the telescope directly, so that you can see that the total difference really in what we're doing for an awake patient. And I suppose we have been working, Rena, we have been working on that for many years now, trying to improve what we're doing on at hysteroscopy, and the support really hasn't been there, and we've been trying to make these things happen and trying to make it a part of normal care. And recently, in Europe and UK and Germany, and the administrators now have discovered that hysteroscopy on an awake patient then will save them expenditure for theatre and operating expenses. And a lot of have introduced what they call a best practice tariff, which really is an incentive, as they call it, to work with high quality and cost-effective care and to reduce unexplained variation. So this, in the course of hysteroscopy and hysteroscopic procedures, this means basically that they want 70% of these procedures to be carried out on an ambulatory awake basis, and thereby saving the health system then from a large part of the cost that would be involved with these. So if you and I, Renu, were coming at it from the point of view of trying to do something good for the patient and trying to have it so that hysteroscopy was a successful procedure and was carried out for awake patients and everybody was happy, then the administrators are now 20 years later coming in and they're saying, oh, this is a great idea, we can save money. And then they're saying, okay, 70% of the women need to have the hysteroscopy awake in order to attract the 100% funding that we're going to give you. And if you don't reach that target, then your funding won't be the same. And so that there is an unnecessary push to do that. And on this slide, this is just, well, this is a composite slide here, but I can show you this part where this is Lynn Brown in the House of Parliament in London last year. And she is saying that the women who started a campaign against painful hysteroscopy are being denied informed consent, and they're having their pain ignored, and they're having trauma as a result of being pushed in to have hysteroscopy awake where they didn't want it. And these women are now saying that they have severe pain and that general anesthetic should be an option for them. So this is something that is, it's unbelievable that it's being debated in the English Parliament. And I think that also in Ireland, this is an Irish publication that was released a few weeks ago. This is the Women and Infants Annual Report. And they are now saying in Ireland that they want an ambulatory gynecology unit in every hospital. And this will lead to a more fruitful expenditure of public money in line with best practice, so that you can see that it's the same thinking is coming out again. And funny enough, the same number here, 70% of general gynecology referrals are suitable for management in an ambulatory setting. So that it's this thinking now is coming through that women can be pushed through and can have awake procedures. Now, the women themselves in the campaign against painful hysteroscopy are saying that they want the options up to general anesthesia, sedation, conscious sedation, deep sedation, general sedation, or they're even asking for spinals, I suppose, which is probably not really appropriate for ambulatory day procedures. But if we look at the evidence, let's say now Justin Clark in Birmingham has produced, and these are recent productions where he did a conscious sedation meta-analysis, and he looked at and found that it did not reduce pain compared to local to oral analgesia and anxiolytic regime, that there wasn't a measurable benefit in the conscious sedation regime. Now, conscious sedation you're looking at there would be intravenous midazolam typically. And he said that they found that there were more side effects with the conscious sedation with women who were having symptoms after having the intravenous regime. So it's not that easy, and it's not that straightforward that you can say, okay, let's give them all a little injection and life will be much easier. Now, if we look here at another publication, this time from Reading, and from an anesthesia group, and they reviewed over 800 hysteroscopies, and they measured the number of local anesthetic amps that were used for these women. So they went and they measured all of the amps of local that were used, and the women were given a pain score chart. So 17% of women had pain greater than 7, which 7 out of 10, 17%, it's quite a lot. Only 7% were pain-free. Now, when they looked at the clinician, they looked at the clinician pain estimates negatively correlated with the anesthetic dose. So whenever the clinician felt that the pain was well controlled, that was in the group of women who had had a lot of local ampules. So he thought, oh, this is great. But when the women were asked for their pain rating, their pain ratings were higher in the group that had had more ampules of local anesthetic. So this was completely different to what the anesthetists or the doctors were feeling, is that the women were feeling the more anesthetic they were being given, the more pain that they were having. So it didn't quite add up, the point of view of the women and the point of view of the doctors. You know, so that really, have we got it organized or have we not? So we'll go back here to Birmingham to the review again. Operative technologies and pain, a systematic review. And basically the finding here was that with mechanical technologies, with morcellators, with scissors, that there was less pain than with the technologies that were using diathermies or that were using a current system. And also interestingly found that the smaller and quicker devices are less painful. So I mean, this is, I suppose, in some ways self-evident anyway, but it is important to remember for an awake procedure, smaller devices, quicker procedures are obviously less painful, but he certainly found that in the systematic review that this has been shown out. And I think this is the direction that we're going in for women who are having awake procedures. Looking again here at another study, again carried out this year, so that they're all very recent now, this interest, I suppose, in pain relief. This is a randomized trial of nitrous oxide, local lignocaine, and no anesthetic. And the visual analog score here was shown to be better with both anesthetic methods, and 47. This is measured out of 100. So the average visual analog score 47 with no analgesia, which is quite a bit of pain, I suppose, that there was a difference. So that I suppose the message from here is that some pain relief is good, although we don't know quite what is the best. Now, one important issue, I suppose, that does help a lot, and that I said at the very beginning, I don't know if you picked that up at the very beginning, as I said, that the women who are complaining of painful hysteroscopy really wanted to have more information. And one of their big complaints is that they weren't aware of what was happening. They weren't aware of what was going to happen to them. They weren't aware that if it got very painful, that they could stop. And a lot of women said that when they felt that there was a lot of pain and that there was too much pain, they felt that they really had to carry on and persist in case they missed out on a very significant diagnosis. And they felt pressured, and they felt that there might be a serious diagnosis, and they felt then that they might lose out, so that they had to go along with it. And I suppose in a lot of ways, that pressure on the women to comply was really what they didn't like. You know, and I think the message really, I think, is that we have to listen to the women. We have to listen to the campaign against painful hysteroscopy. And we have to be able to say to them, okay, when they sit down and when they say, okay, I prefer to be asleep, then we can say, okay. You know, there is a pushback, and I think certainly in a system that is being introduced now in Ireland and has been introduced in a lot of certainly in a lot of European countries, where they're introducing ambulatory gynecology as a significant part of the healthcare provision for women. I think that we need to be able to take that into account, and we need to be able to reach an agreement with women. On the one hand, we'll do our best. We will provide good hysteroscopy care for awake women. And I think using information, using well-trained doctors that can use procedures with smaller instruments that are quick and that are not prolonged, which is leading to the discomfort, and that they can use a proper regime. Now, it hasn't been shown yet what the best regime is for pain relief. So I suppose at the moment that one is up for grabs. But certainly, if a woman says she wants general anesthesia, she needs to be listened to. Renu, I think we had a lot of video today anyway, so the guys are okay with the video. So I think they're all right. I'm very sorry that our little link is kind of didn't get it, but it doesn't really matter. You know, there were just, I think that the videos were just to illustrate really what I was saying. You know, they were just showing the way that we can certainly do that with the wake hysteroscopy.
Thank you so much, Mike. And I'm glad that, you know, that people are listening to women, because there is so much push towards ambulatory surgery, ambulatory, no anesthesia. But I mean, not all women are happy. In fact, in India, when I was in UK, like there were a lot of women who were happy getting hysteroscopy done without anesthesia. In India, hardly 10% opt for hysteroscopy without anesthesia.
Yeah.
So I'm glad that we're not pushing women, you know, against their will to go into, you know, procedures where there is pain. I mean, there's no doubt. When you put yourself in the patient's shoes, then you know that it hurts. And it's not a nice feeling when you know it's going to hurt, you know, I mean. So
I think, Rena, maybe it's going to happen. Maybe in 5 or 10 years, they will be pushing and they will be saying, oh, we must do this, you know, and that's what's happened here. They say the women must have that, you know, it's best practice. So that's how it happens.
I mean, I think the women should be making the choice whether they want it without anesthesia or with anesthesia or with sedation, rather than the doctor. Because like you showed in your slides, you know, doctors always underestimate the pain. They say, no, you're fine, you're fine, you know, and she's not fine actually, and she doesn't want to open her mouth and say so. So
I think so.
Thank you so much. And thank you so much for waking up early to deliver this.
No, I'm delighted. I'm sorry our communication was a bit, I don't know what happened, it was a bit.
Yeah, I don't know why
it wasn't good.
Videos didn't run. But anyway.
Okay. Take care of yourself.
Thank you. Thank you so much.
Bye.
Thank you for joining. Thank you. So am I audible in the hall? Juhi? Am I audible in the hall? I can't hear you, Juhi. Unmute yourself, Juhi. Yeah. Am I audible in the hall?
Yes, ma'am.
Okay. So I would once again like to officially thank Professor Michael Gannon on my own behalf and Dr. Neena Malhotra, who is the convener of the workshop.
And you're not audible right now.
Not audible?
There's some problem with the audio transmission.
I can hear you. You can't hear me? Maybe they can.
Audio from the OT.
But you can hear me, Mike.
Oh yeah, I can hear you clearly. Yeah.
Actually, now we can hear you.
Okay. The problem is this three-way: OT, conference hall, and the Zoom. So I think that's the problem. Anyway, you can hear me now in the hall. Okay. Anyway, so I would like to thank him officially on our behalf. And to me, any hysteroscopy workshop or conference is not complete without having him on board. And so it's a pleasure to have you, Dr. Gannon. And I would now like to thank all our OT staff, the nurses, the technicians, the anesthetist, of course, to give us, everything went smooth. There were no problems, no complications. All cases had good anesthesia, no problems on our end. So that was good. In any live surgery workshop, you're always worried that, all patients should go home safely and that we are able to do what we had planned for those. So all the patients have had surgeries, what they were planned for. There were no surgeries abandoned. And then, of course, I would like to thank Dr. Sudha Prasad, the President IFS, and Dr. Neena for giving us this opportunity to hold this hybrid workshop at AIIMS and on the Zoom. And thank you all. I cannot see the audience in the hall, but thank you all who've come physically to this workshop. I know nowadays everybody feels comfortable attending online Zoom, and it's become more of effort now to come for a physical presence. But I hope you all enjoyed, and I hope you all had a go at the Histro trainer, which was put up very kindly by Karl Stores. And the whole equipment was provided by Karl Stores, so I must thank them. They brought their latest hysteroscopes, the Camper Trophy, which in fact I have and ended up using equipment which I never used before. So it's actually a great advantage to me for doing this workshop. So I used the Bugatti shaver for the first time. I used the Camper Trophy for the first time, which I really liked, because it saves you from changing instruments, from taking the diagnostic out and then putting the operative sheath. So I think that is a very, very good addition to Karl Stores armamentarium. So thank you, Karl Stores, for giving us this support. And of course, AIMS, OT staff, and the AIMS administration for allowing us to conduct this workshop at AIMS on a Sunday, where it is a holiday for everybody. You can see so many people around us, because of a workshop. The whole OT is full. So thank you all. And with that note, I would end this workshop. Thanks once again. Stay safe.
Thank you, ma'am. Thank you, everyone.
Okay. So
Thank you,
thank you. So we are going to come down for lunch. Okay. Mike, you can have breakfast in Dublin.
Thank you very much, Ranu. Thank you. I hope you have a nice day.
Bring the breakfast to me.
Bye.
Thank you. ये लीजिए आपका लैपटॉप। Zoom लिंक क्या बंद कर दे?
हाँ जी, बंद कर। अच्छा, मैम से बात करने के लिए बोल रहे हैं। हेलो, बोलो। हाँ बोलो। फीडबैक आ रहा है।
कौन बोल रहा है?